Well, good morning, everyone. Welcome to Pestola 2021. I am Rona Sonnabend, and I have the esteemed pleasure and honor of being the section chief here at Texas Children's Hospital, and welcome you all to Pestola this year. In different years and in different times, we would be welcoming you here to Houston, and welcoming you to our rodeo season, or as my children call it, really the most magical time of the year. This year, however, we thought we'd add just a little bit of spice to what has otherwise been a really unremarkable and quite undramatic year, and bring you a Texas-sized ice storm filled with political intrigue and political suspense. And so we're so grateful to all of you and to the Pestola leadership for allowing us to reschedule this so that we could all be together and we could all welcome you with power and electricity. We are so grateful to all of you for joining us today, what we hope will be just a wonderful learning opportunity and a wonderful learning session. Please allow me to introduce our incredible moderator for today's activities, Dr. Daniel DeSalvo. Dr. DeSalvo is an assistant professor of pediatrics in the section of diabetes and endocrinology here at Baylor College of Medicine, Texas Children's Hospital, where he serves as our director of strategic collaboration and our type 1 diabetes lead. As a pediatric endocrinologist, his greatest passion is to help children live well with diabetes, and it considers it a remarkable privilege to shepherd those families in their journey. He currently serves as our Type 1 Diabetes Exchange Quality Collaborative lead, our Beyond Type 1 Scientific Advisory Council, and the College of Diabetes Network Clinical Research Advisory Committee. He's a patient-oriented clinical researcher, and his primary focus is on emerging diabetes technology, including continuous glucose monitors, insulin pumps, and closed-loop automated insulin delivery systems. Daniel, if you haven't met him yet, is what my grandmother affectionately refers to as the greatest mensch of all times. So I welcome Daniel, and I'm so grateful that Daniel is going to be our incredible moderator for today. And I welcome all of you to visit Houston in other times under different circumstances. Bye.
Well, thank you, Dr. Sonnabend, for that warm Texas welcome. And I'm so grateful to be with all of you virtually. And I look forward to an outstanding lineup of speakers today. As Dr. Sonnabend mentioned, in January of last year, when we were selected to host Pestola 2021, we quickly began planning for the meeting. We chose conference space, we booked hotel rooms, some great restaurants here in Houston that we were hoping to bring you all to. But then COVID-19 hit, and we thought, surely in a year from now, we can get together in person, but man, were we wrong. So then plan B, we planned for a virtual event on a Saturday in February. Then the Arctic blast hit. And so here we are with plan C. So thank you all for your flexibility and being nimble and joining us here today. As a reminder, there will be CME credits offered for attending Pestola. You can expect to receive an email from Pestola in a couple of weeks with very clear instructions on how to obtain your CME credits through Texas Children's Hospital. So stay tuned for that email. I'd also like to remind everyone that there is a virtual poster hall that's posted on the Pestola website, which is pestola.org/poster-hall, as shown right here in the screen. Also, there should be a link in the chat box. To kick off Pestola 2021, I'm really excited that we'll be hearing from some of our featured fellows. We had dozens of excellent submissions from fellows across member institutions, and the three who will be presented today were specifically selected by the Pestola Organizing Committee for their very strong abstracts so they can showcase their work with an oral presentation. If you have questions for presenters throughout the day today, please see the Q&A button below on your Zoom screens. That Q&A button is where you can submit questions, which I'll be looking at and moderating and presenting those to the presenters. So without further ado, I'd like to present our first speaker, Dr. Olivia Guinard, who's a second-year fellow here at Texas Children's and Baylor College of Medicine. She's also a researcher in the postdoctoral fellowship program at the Children's Nutrition Research Center with a focus on vitamin D, obesity, and insulin resistance. And today, Olivia will be presenting an interesting case of diabetes with multiple islet cell antibody positivity, successfully managed with GLP-1 receptor agonist alone. So Olivia, take it away.
All right, thank you. Let me just share my screen here. Okay. All righty. Well, thank you, Dr. Sansalvo, for that wonderful welcome. So hello, everyone. I'm Olivia Gennard. And so today I'm going to be talking about a very unique adolescent with a mixed diabetes type phenotypic picture and our approach to his management. Of note, no financial relationships or other conflicts of interest to report. So before presenting his specific case, I wanted to discuss a little bit of background to help better understand our particular approach for this patient. So with just some review of currently accepted definitions regarding type 1 diabetes, the defining pathophysiology being that insulin deficiency results from the autoimmune beta cell loss. And so as this autoimmune destruction of beta cells progress, individuals go through stages of normal glycemia, then dysglycemia, and then finally to frank hyperglycemia, which is typically present at the time of diagnosis. In fact, 90% of patients diagnosed with type 1 diabetes present in this fashion as this result of this documented progression of autoimmune destruction of beta cells. In contrast, in type 2 diabetes, it's been more defined as a progressive loss of insulin secretion and the background of insulin resistance. However, with the advent of genomics and multi-center studies, researchers are beginning to see a caveat to this typical paradigm. For example, with the Today study, we saw that 9.3% of their patients with clinical type 2 diabetes actually had positivity for islet autoantibodies. And 14.4% of those with biochemically diagnosed type 2 diabetes actually did not have acanthosis nigricans. In the UKPD study, 4% of those patients that had a clinical diagnosis of type 2 diabetes were positive for GAD65 and IA2 antibodies. And then when considering some deviations from the typical presentations of type 1 diabetes, the search study found that 12.6% of their patients diagnosed with type 1 diabetes were obese. And in a study from the Barbara Davis Center, they found actually that 10% of their patients with clinical type 1 diabetes, specifically children with 5 years of age or younger, were actually negative for any islet autoantibodies at the time of diagnosis. So therefore, the underlying pathophysiology and subsequent classification of diabetes appears to be much more complicated and heterogeneous than previously thought. It's possible that we can better describe this using a palette model or an endotype disease model, where this is focusing on all the different defects that can occur anywhere along these multiple pathophysiologic pathways of diabetes and result in these various phenotypic presentations. So in the model presented by McCarthy, the palette model, you see these base colors here on the left, and those represent these pathophysiologic traits and processes such as islet cell destruction, beta cell number, islet function, insulin resistance, incretin activity, obesity. And then for each one of those, there's this spectrum of phenotypic variation that contributes to the individual risk of diabetes. Therefore, this disease pathology of each person results is a sum of their genetic variation, non-genetic exposures or risk, and this really results in their different phenotypic presentations. In the endotype disease model proposed by Battaglia, they describe this model as a subtype of type 1 diabetes that can be defined by distinct functional or pathobiological mechanism. Specifically, the proposition is that by developing endotypes based on these pathophysiologic processes that underlie type 1 diabetes, we can better tailor and make a personalized medicine and adapt specific modifying disease therapies, as an example, immunotherapy. More specifically, you can make an endotype, for example, based on a phenotype, like a specific islet cell autoimmunity, and link it to its genotype, so using HLA genotyping. Then you can further classify or elucidate a subtype using age and sex due to those individual differences that we know and effects on immune and metabolic functions. or you can even use the patient's drug and treatment responsiveness. And again, this is prompting that precision medicine idea. Then in addition to these models and concepts, with the increased availability of genotyping and whole exome sequencing, other hypotheses can be considered that focus more on the genetics and environment, and then how those contribute to the specific phenotypic variations of diabetes. But all in all of these models and concepts highlight this increasingly complicated task of trying to classify diabetes given the need to incorporate all of these different factors. In fact, very recently, the Precision in Medicine Diabetes Consensus Report emphasized that the best diagnosis of type 1 versus type 2 diabetes depends on integrating all these diagnostic modalities. With that background provided, let's go ahead and discuss this unique patient. So this was a Caucasian 14-year-old adolescent male with obesity, hypertension, asthma, allergic rhinitis, autism spectrum disorder that was referred to Texas Children's Endocrinology Clinic for the further evaluation and management of a new diagnosis of diabetes. 2 months prior to this referral visit, the patient was seen by their primary care provider for abdominal pain and hypertension. Upon further workup, it was found that he had a hemoglobin A1C of 10.3 and hyperglycemia, specifically blood glucose of 290. And at that point, a diagnosis of diabetes was made. Further laboratory work revealed that his lipid and liver function panels were normal, and he did not have any acidosis or ketosis. With that diagnosis of diabetes, he was then started on 500 milligrams of metformin twice daily and referred to our clinic. 1 month after that, additional labs obtained or resulted included an A1C of 8.5%. Again, this is being on metformin for 1 month. And then his islet autoantibodies resulted with strong positivity, including GAD65, IA2, and zinc. His random insulin and random C-peptide levels resulted to 69 and 7.5 respectively. With the C-peptide, it was a stimulated C-peptide. However, we don't have the glucose data available for the exact glucose numbers at that time. And then he also had thyroid peroxidase antibody positivity with normal thyroid function. Then at presentation to our clinic, which was 2 months after starting metformin, his physical exam revealed obesity in the 98th percentile and a Z-score of 2. He had no acanthosis nigricans, and he completed puberty with Tanner stage 5 genitalia and pubic hair. With regards to the lab work, his blood glucose log revealed blood sugars between 77 and 180, and his A1C was 7.6. Upon further medication check, just to make sure nothing else was going on, he had no medications for autism spectrum disorder, nor was he on any inhaled or oral glucocorticoids. So a plan was made to titrate the metformin to 1,000 milligrams twice daily. However, the patient did not tolerate this. He had GI side effects, and he actually had exacerbation of some behavioral issues related to his underlying autism spectrum disorder. So the family really wanted to stop metformin and wanted to avoid insulin therapy as well. So a shared decision was made to start liraglutide at 0.6 milligrams daily. So 3 months after switching the medications, we got additional lab work. His blood sugar logs were between 74 and 110 as far as his blood glucoses, and a random insulin was obtained that was 37. He no longer had any side effects, and his behavioral issues had subsided. His dose at that time was increased to 1.2 milligrams daily. And then currently, his dose is 1.8 milligrams daily of liraglutide. He was recently seen via telemedicine, but last clinic visit, we had a hemoglobin A1C obtained that was 5 7.7%, which is meeting the ADA requirement or recommendations of less than 7% for children and adolescents. And he also had lost 5.1 kilograms from the start of or time of diagnosis with a current weight of 85.9 kilos. So as a brief summary of his clinical course, at the time of diagnosis, he was found to be obese, had autoantibody positivity very strongly in 3 antibodies. His hemoglobin A1C was 10%, and at that time, metformin was started. 1 month later on metformin, his A1C decreased to 8.5%. At that time, his C-peptide level was robust. 2 months after diagnosis, his hemoglobin A1C further decreased to 7.6%. This was the time that we changed from metformin to liraglutide. And then 5 months after diagnosis on liraglutide, his hemoglobin A1C met ADA requirements at 5.7%. His C-peptide remained at robust levels at 4.8, and his BMI improved. So this case presented some very interesting lessons related to an atypical presentation of diabetes. The classification of diabetes has evolved over time to really reflect our developing understanding of the underlying pathogenic processes. No longer do we classify based solely on age of onset or method of treatment. However, despite these regularly updated and current classifications that we use today by the ADA and the WHO, we clinicians over the past decades have been seeing individuals where this classification system just doesn't seem to be adequate, and more individuals with that seemingly mixed diabetes picture or double diabetes. Again, likely due to these underlying different diabetogenic processes that can vary between individuals. As an example, in our patient had evidence of type 1 diabetes mechanisms with the strong islet autoimmunity, the lack of acanthosis nigricans, and the TPO antibody positivity. However, he also had strong evidence of type 2 mechanisms, including obesity, hypertension, response to metformin. He didn't have DKA, he didn't have ketosis, and he had very robust C-peptide levels throughout his management. So one could question or ask, well, what if this was just early diagnosis, or what if this was the honeymoon phase? While beta cell function can be fairly preserved and conserved in type 1 diabetes very early on in the process of autoimmune destruction or early in diagnosis of the beta cell destruction, these cases are typically characterized by relatively low blood sugars and relatively low A1Cs, which was in contrast to our patient who had an elevated A1C at already 10% and hyperglycemia at 290. Neither is this case really consistent with that partial remission or honeymoon period that we see in type 1 individuals, where they experience this decline in average blood sugars and A1C as a result of a partial beta cell recovery after the initiation of insulin therapy. Our patient actually had continued robust C-peptide levels, and this was attained with non-insulin therapy. And that particular course is more consistent with a type 2 diabetes progression, or seen in type 2 diabetes. I should say of note, we keep saying random elevated C-peptide levels. Just a reminder that this is an appropriate surrogate marker for beta cell function when we don't have the availability of mixed meal tolerance stimulated C-peptides. So then these nuances in these diabetes phenotypes are important when you're trying to determine what treatment, and it really accentuates that need for individualized medicine with regards to diabetes. This case specifically suggested that liraglutide may be appropriate in some individuals that demonstrate this mixed diabetes phenotype, such as our patient, where he had evidence of beta cell reserve despite having very strong islet autoimmunity and marked hyperglycemia at the time of diagnosis. So just brief review that liraglutide is a glucagon-like peptide 1 receptor agonist, where it acts to increase insulin secretion, delay gastric emptying time, and increase satiety. They have traditionally been used in the treatment of type 2 diabetes in adults since 2010, and in 2019, the FDA approved them for use in type 2 diabetes in pediatric patients of 10 years of age or older. There have been some studies investigating the use of these GLP-1 receptor agonists potentially to preserve beta cell function in individuals with type 1 diabetes, but those have been met with very mixed results. And for example, Pestola recently did a very large randomized trial looking at this very question, and he showed only a transient preservation of C-peptide levels over time, and really no effect on hemoglobin A1C or glucose control. Therefore, when considering liraglutide as treatment in a patient with diabetes, GLP-1 receptor agonists may not be the most appropriate initial therapy option with individuals that have that classic type 1 diabetes picture. However, for those individuals with that mixed phenotype, double diabetes, or the presence of multiple diabetogenic processes, this might be a reasonable treatment modality to consider. However, when you're using these in these unique cases, we recommend very close monitoring of the patient's progression by measuring C-peptide measurements and blood glucoses, and as needed or as appropriate ketones. For example, for our patient, the plan was already discussed with the family that we will be starting insulin once we see the C-peptide levels decreasing. So in conclusion, some clinical pearls to really take away from this case was that diabetes classification is much more complex than previously thought due to all these multiple pathophysiologic pathways of diabetes. Treatment should be personalized for each individual and their unique underlying diabetes disease process, and that liraglutide therapy may be appropriate for those individuals that demonstrate that mixed diabetes phenotype. So in addition to thanking the patient and his family, I'd also like to thank Dr. Sarah Lyons and Dr. Maria Redondo for help with managing this patient, but also helping with the discussion and review of this case. Thank you.
Thank you, Olivia, for a great presentation. What an interesting case of this mixed phenotype of type 1 and type 2 diabetes. I'm wondering, at that point, 1 month after diagnosis, when the A1C was 8.5% and had this strong autoantibody positivity, the decision point to use liraglutide as opposed to insulin, it turned out to be the right decision, but I'm wondering how that was made. I think sometimes we get a little bit gun shy because of concerns about risk for DKA. How was that clinical decision made to start the liraglutide at that point?
So actually, when the patient came to us, he was already on metformin because he came to us about 2 months after diagnosis. And so because of that, we saw the continued decrease with being on metformin. He had no evidence of ketosis or acidosis, so we weren't as concerned with that risk of DKA, despite that high presentation of hyperglycemia and A1C. And, we just gave it a try because metformin had been, keeping him safe and not prompting him, to continue on with more of like what you think of a beta cell destruction process where potentially you could have DKA. And so in that case, we did feel a little bit more comfortable switching. Of course, we kept a very close eye and gave them close monitoring parameters and, when to call us, when to be seen and things like that. But I think because of his particular presentation and the fact that he already came on only metformin to us for 2 months with decreasing A1C, I think that's what prompted us to be comfortable to do that. Got it.
We have a couple of questions coming in about the liraglutide dose. One question is about why did you decide to increase it? And was there any hypoglycemia on the 1.8 milligram? Another viewer asked, have you considered increasing it further to help with the weight loss? So could you speak a little bit about the liraglutide dosing?
Sure. So we started at the typical 0.6 dose. And as we know that, especially getting closer to adulthood and the impact of puberty, that's not the ideal dose to actually make an effect on their glucoses, even though for his he did. But we then titrated the typical dose of 1.2. He still had some intermittent hyperglycemia, but no side effects. So we felt comfortable going to what I think a lot of other providers might consider the more higher dose that we typically would use would be the 1.8. And that was also in part to help prompt a little bit more of the benefit of weight loss. But we haven't considered going up. I don't know, maybe that's a good point in the future, but he seems very controlled and is consistently now losing weight. So I think we're comfortable at the dose currently.
Great. Well, thank you again. And at this time, I'd like to present our next speaker. Dr. Katie Kerr is a second-year fellow at Long School of Medicine at the UT Health Science Center in San Antonio. She's conducting research related to molecular markers and thyroid nodules. And today, she'll be presenting a case of radioactive iodine-resistant pediatric papillary thyroid carcinoma. So Dr. Kerr, take it away.
Thank you, Dr. DeSalvo. And it looks like I need access to share my screen still. Let's see. Okay, thank you. All right, thank you so much. I've had the distinct privilege of working with Dr. Francis on this case, who is a thyroid cancer expert here at UT Health in San Antonio, and just love to have this opportunity to talk to you all about so much of what I've learned there during this year. I have no financial disclosures or conflicts of interest related to this topic, and we'll be discussing FDA-approved and non-approved treatments. So how common is pediatric thyroid cancer? We see thyroid nodules in 0.2 to 5% of children and up to 13% of adolescents. In obesity, certain ethnicities, and radiation exposure history increase the risk. The risk of cancer in a pediatric thyroid nodule is between 22 and 26%, whereas in adults it's much lower, between 7 to 15% in their thyroid nodules. In pediatrics, differentiated thyroid cancer is mostly papillary, and our treatment options are surgery and radioactive iodine, with few other options. There tends to be a very good prognosis, even if the patient presents with metastatic disease. Radioactive iodine refractory thyroid carcinoma is rare in pediatrics, and there are several definitions depending on how your patient progresses. One is loss of radioactive iodine uptake over time, uptake in some lesions but not all, progression of metastases despite uptake, and progression of disease despite surgery and radioactive iodine, especially if the cumulative dose is over 600 millicuries. A drug class called tyrosine kinase inhibitors is FDA approved for thyroid carcinoma in adults, but not yet in children. Our patient was diagnosed with thyroid cancer at age 15 in 2016. She presented with a painful neck mass, and by exam and ultrasound was found to have a 1.5 centimeter necrotic right thyroid nodule and large firm necrotic cervical lymph nodes. On fine needle aspiration, the nodule and a lymph node were both positive for papillary thyroid carcinoma. She got a CT scan with scattered 2 to 3 millimeter pulmonary nodules in both lung fields. So here's her CT scan. And I'll just point out a few of these very small but numerous nodules on both sides. She underwent total thyroidectomy and central and right neck dissections and was found to have a 1.9 centimeter primary tumor in the right lobe, shown here. There was lymphovascular invasion, and 23 out of 49 nodes were involved with extranodal extension. She was diagnosed with unifocal classic papillary thyroid carcinoma, staged T1N1B M1, and she was labeled as high risk for persistent cervical disease. The remainder of her course is shown here. On the x-axis, we have time in months, and on the y-axis, we have her lab measurements. Here in orange on the left is thyroglobulin antibody, and in gray on the right, thyroglobulin by tandem mass spectrometry. We began measuring her antibody levels since she was positive for these. This would make the standard immunoassay for thyroglobulin antigen inaccurate. So that's why we started with the antibody. After her surgery in July 2016, she received I-131, 152 millicuries. Her whole body scan post-therapy showed mild diffuse uptake in bilateral lung fields, which was consistent with her preoperative CT scan. And initially, she had a nice response in her labs with her antibody decreasing from 2,700 to less than 500. However, on following this further, about a year after therapy, she still remained right around 500 with her antibody level. And this prompted further workup with an I-123 scan. This scan showed no change at all from the prior post-therapy scan. And so because of that, she received a second dose of radioactive iodine, this time 203 millicuries. And the whole body scan after this therapy showed an increase in uptake from the prior scan. So here on the left is her first post-therapy scan with mild diffuse uptake bilaterally and more uptake in a mediastinal node. And her second post-therapy scan shows definitely increased uptake on both sides, again with this persistent node. After therapy, she had an increase in thyroglobulin antibody, but this can be expected after just a few months after therapy before it goes down. She also had pneumonia at the time, and when the CT scan was performed, it showed not only pneumonia, but as you can see here on the right side, increase in number and size of her nodules. And now these are pretty well enumerable on both sides. And on the left here for comparison is her preoperative CT scan. And of course, the right lower lobe active pneumonia. After this, we obtained our first thyroglobulin by tandem mass spectrometry level, now 2 years after surgery, which was almost 4,000 nanograms per ml, which is very high. But this was our first measurement, so we decided to continue to monitor her. And the next measurement 7 months later was still above 3,000. So this prompted concern that she was still either progressing with her disease or at least still persistent. And the CT scan at that time was unchanged from this previous one. So she did have a third dose of radioactive iodine, this time 250 millicuries for a total cumulative dose of 605. And after this, she experienced some shortness of breath and sialadenitis, indicating radiation damage. Her whole body scan again showed increased uptake from her previous scan. So this is very interesting because if we go back and look at what were our definitions of RAI resistance, she certainly does not have loss of uptake now on her third treatment. She could have uptake in some lesions, but not all. She certainly has progression of metastasis despite uptake. And now she's had surgery and radioactive iodine greater than 600 millicuries. So she does fit some of these definitions of resistance. But our next thyroglobulin by tandem mass spec was encouraging because now we're finally below 3,000 nanograms per ml. And so in continued monitoring of her at this time, we were encouraged. But the next level was greater than 7,000. And now she's 4 years out from surgery. And this is just totally unacceptably high. And the CT scan as well was again dramatically increased, size and number of nodules. So for comparison, on the left is her CT scan after her second dose of RAI, and now we're after her third dose. And these are innumerable. It's harder to find the normal parenchyma than it is to find a nodule. So it was very clear at this point that we would need to engage some other form of therapy. And looking at tyrosine kinase inhibitors, we wanted to try to see if we could find a targetable mutation or gene fusion. So we biopsied one of her pulmonary nodules, but unfortunately could not find a targetable mutation. So lenvatinib was started, which is a non-specific multi-target tyrosine kinase inhibitor. So let's talk some more about this drug class. Some important growth factors in cancer biology include VEGF, PDGF, FGF, and RET. These exert their effects through receptor tyrosine kinase and activation of these pathways, including RAS, RAF, MEK, ERK, and PI3K, AKT, and mTOR pathways. There's complex crosstalk between these pathways, and they can be activated by factors in the cell other than the receptor tyrosine kinase. This crosstalk provides a mechanism for tumor cells to escape therapy over time. Drugs have been developed to target some of these specific molecules, including BRAF, MEK, and mTOR. However, our patient did not have a targetable mutation, so we targeted the receptor tyrosine kinase upstream with this drug, lenvatinib. Lenvatinib is used in adults for advanced thyroid carcinoma, including poorly differentiated and anaplastic types. It primarily impairs angiogenesis. It fails to induce remission in the majority of patients, but there's a significant increase in progression-free survival in many patients. In the phase 3 SELECT trial, PTC patients had increased progression-free survival with a median of 12 to 18 months. And 75% of patients responded to therapy. 4 achieved complete radiographic remission, which is not many, but it's more than 0. And unfortunately, though, 67% required a dose reduction and 14% discontinued the drug altogether. That's because lenvatinib has a lot of side effects: hypertension, diarrhea, and fatigue in more than half the patients. And this thing called hand-foot syndrome, also known as palmar plantar erythrodysesthesia, which causes painful blisters in the hands and feet. In many patients, in one Korean study, up to 50%. And there was nausea, decreased appetite, and weight loss in many patients. Our patient had most of these symptoms, including most notably severe diarrhea and fecal incontinence. And the blisters on her feet were so bad that she was unable to ambulate for a lot of her course so far. So in June, she was started on 24 milligrams of lenvatinib daily, but this was decreased 3 months into therapy to 20 milligrams because of her side effects. Gabapentin was added in October, which did help some with her painful walking, but she just still continued with pain and diarrhea, and this dose was decreased again in January to 14 milligrams. But she has had a remarkable response so far. So here is her CT scan from October after only 3 months of lenvatinib, markedly improved in number and size of nodules from her previous CT scan. And not only that, but her thyroglobulin level has decreased from 7,000 to 94 nanograms per ml. And that is after several months of a decreased dose. And in January, she also had a stable CT scan that still looked much better from the previous. So this was a wonderful response so far, but we do have some major questions remaining for this patient. How long will she tolerate this drug? She's already had 2 dose decreases and some life-changing side effects. How long until the tumor cells escape the effects of lenvatinib? In adults, there was a median progression-free survival of 12 to 18 months. We don't know how that applies to her cancer. Can we give more radioactive iodine? Should we try some other drug, maybe one of the other drugs in the pathway downstream? Or should we watch and wait? We discussed her at a multidisciplinary tumor board and decided that for now we'll watch and wait with serial imaging and thyroglobulin measurements. We learned that adults may remain stable on as low as 10 milligrams of lenvatinib per day, even for years. And for our next scan, we'll consider an I-124 PET-CT scan, which can quantify uptake in individual lesions for a potential future dose of radioactive iodine. We're going to plan on sending her prior biopsy material or even potentially a new biopsy sample for further molecular testing in search of a targetable mutation as her cancer changes and as new targets are discovered. And we'll consider other therapies if she does not tolerate this lower dose of lenvatinib or if the disease burden increases. So far, she's been doing better on this lower dose, 14 milligrams. In conclusion, radioactive iodine resistance is rare in pediatric thyroid cancer, but when it happens, there are few therapeutic options for us. And molecular guided therapy with TKIs is promising in thyroid cancer. So thank you all so much. And thank you so much to all my wonderful mentors who helped me along the way.
Well, thank you, Dr. Kerr, for another great presentation. Can you speak a little bit about the role of the multidisciplinary team in this case, including the decision to start that tyrosine kinase inhibitor?
Yeah.
Was this mostly endo? Was oncology working with you as well? How did you guys come to that clinical decision?
Yeah, we have a monthly tumor board with nuclear medicine and adult endocrine. So it's adult endocrine, including a endocrine oncologist who has treated several patients with TKIs for advanced adult papillary thyroid carcinoma and other types of thyroid cancer too. And so we all talked about this patient, and that's how we kind of came to our decision, and also gained the knowledge about some of her patients, which have done very well on low doses of lenvatinib for several years, she said. So that was really encouraging.
So there's a question from Dr. Horn who asked about concerns about stopping this pathway inhibitor. Is there a concern that the tumor could actually grow more progressively after stopping? And to that end, what are you thinking about in terms of the next agent you might use? You spoke to this a little bit, or if you might consider radioactive iodine again for her.
Yes, so all of those things are on the table. I think there's certainly, we would not like to do another dose of iodine if we don't have to. But if she responds to it, especially with a low tumor burden, it's our only potentially curative option. If she cannot tolerate lenvatinib, there is another receptor tyrosine kinase inhibitor that we could switch her to. And there's some adults who have used, adult patients who've had a combination of lenvatinib and a MEK inhibitor and had some success on that as well. So those things are also potential, but yes, it is really concerning just to stop her therapy, and just considering her past progression of disease and persistence despite our treatments.
Okay. Well, thank you again. And at this time, I'd like to go ahead and present our next speaker. Dr. Maha Youssef is currently a second-year pediatric endocrine fellow at UT Southwestern Medical Center in Dallas. And today, Dr. Youssef will be presenting on a severe case of Graves' disease with a management dilemma concerning thyrotoxicosis. So Dr. Youssef, you're on.
All right. Good morning, everyone. So I'll be talking about a very severe case of thyrotoxic crisis that presented a very interesting management dilemma. Dr. Abid Chaudhary is my advisor on this case. So as we all know, thyrotoxic crisis is one of the most critical endocrine emergencies. It is very rare. Incidence of thyroid storm overall is about less than 10% in patients who are hospitalized for the management of thyrotoxicosis, but carries quite a high mortality rate of up to 20 to 30%. The most common etiology is Graves' disease, but can be caused by dissected thyroiditis, toxic multinodular goiter, metastatic thyroid cancer, post-radioiodine therapy, medication-induced, amongst others. The diagnostic criteria for thyroid storm is based on the Birch-Rotowski point scale, as noted here, with a score of greater than 45, highly suggestive of impending thyroid storm. The management of thyrotoxic crisis involves the 5 P's that we know that we've learned moons ago: blocking new hormone production, peripheral beta-adrenergic blockade, preventing peripheral T4, T3 conversion, inhibition of thyroid hormone release, and enhanced hormone clearance. With those being, blocking hormone production is very, very important using methimazole in the pediatric population. Methimazole is usually kind of well tolerated, but one of the most serious side effects of its use is agranulocytosis. In this case, we present a patient that was unable to be treated using this conventional modality. So our case presentation, so the 16-year-old African-American female that was diagnosed with Graves' disease about 4 months prior to this admission, presented to the emergency department with sore throat, altered mental status, gait instability, fever, weakness, and palpitations. She had been diagnosed with Graves about 4 months prior after presenting with a few month history of weight loss, palpitations, heat intolerance, and restlessness. At that time, she was discharged home on methimazole 25 milligrams twice daily, which is a dose of about 0.7 per kilo per day, along with atenolol and SSKI. Interestingly, she had only been given a 1 month supply of this methimazole with plans to follow up in clinic and adjust doses as needed, but she was unfortunately lost to follow up. And by the time she had presented to the ED, the Guardian reported that she still had about 50 pills from that original prescription remaining at home. So she was very non-compliant with her therapy. She had an interesting family history in that her younger sister also had Graves' disease and a maternal grandmother with Graves' disease as well. The sister was actually diagnosed with Graves' disease at 13 years of age, and she was admitted to a PICU actually in New York with severe thyrotoxicosis that was complicated by encephalopathy with EEG changes showing diffuse slowing. At that time, the sister was treated with methimazole beta blockade and SSKI and has been reportedly doing well. On exam, she was quite febrile with a temperature of 40.1 degrees centigrade. Her heart rate was 170. She had a respiratory rate of 27 and blood pressure was 134/90. She appeared very dehydrated on exam. She was altered and agitated. She was able to respond to some commands. There was a thyroid goiter not noted, but no nodules palpated. She was quite tachycardic, but had normal S1, S2, and there were no murmurs appreciated on exam. On abdominal exam, she had distributed some guarding, but no hepatosplenomegaly was noted. On evaluation, on initial labs, her CBC was concerning for a total white blood count of 0.6 with an absolute neutrophil count of 0. She had a normal hemoglobin and hematocrit, and platelets were also unaffected. She had an elevated CRP of 11.2 milligrams per deciliter. Her CMP was remarkable for a very low sodium of 127. The remainder of her electrolytes were normal, and she had a normal BUN and creatinine. She had normal liver function, but had an elevated total bilirubin at 6.2. Her thyroid function labs returned with a suppressed TSH, quite elevated free T4 of 8.95, and a total T3 of 428. EKG obtained shows sinus tachycardia, but mild QTC prolongation to 475. BNP was quite elevated at 766.5, and troponin was elevated as well at 0.627. CT head was obtained in the ED, showed no acute intracranial process, and her CT abdomen was unremarkable, but did note some cardiomegaly. So at this point in time, we were of course consulted. She was definitely in thyroid storm with a Birch-Woodskowski score of 95. She had evidence of cardiac dysfunction, possibly some high output cardiac failure. Hyperbilirubinemia, there was concern for sepsis, and then the severe agranulocytosis was a severe concern. So her management that evening started on broad spectrum antibiotics appropriately. She had received multiple fluid boluses as well. On our discussion, we had decided not to initiate methimazole that evening, given the severe agranulocytosis, but given her significant tachycardia, we decided to proceed with 1 dose of IV propranolol 1 milligram and start her on IV hydrocortisone 25 milligrams every 6 hours. Shortly after receiving the IV propranolol dose, she became hypotensive with systolics down to the 80s. Norepinephrine infusion was initiated in the ED. Immediately, hydrocortisone was increased to 100 milligrams Q6, and SSKI and cholestyramine were added. She was transferred to the PICU. Her blood pressures had improved with the norepinephrine infusion. Now systolics were around the 110s, but she had profound refractory tachycardia with heart rates persistently in the 150s. At that point in time, we decided to initiate esmolol infusion at a very low dose of 25 micrograms per kilo per minute. This is about 2 to 3 hours after she had received the IV propranolol in the ED. 20 minutes after the initiation of the esmolol infusion, she developed bradycardia with heart rate down to the 40s, and then proceeded to PEA. She was arrested, required 6 minutes of CPR, given 2 code doses of epinephrine and 1 dose of bicarb prior to the return of spontaneous circulation. She was subsequently intubated. Epinephrine and vasopressin infusions were added to the norepinephrine infusion. as well. Post-arrest, cardiology was consulted, and on review of her telemetry, they noted that the arrest was secondary to complete AV dissociation following the ismolol initiation. Echo showed severely diminished LV systolic function with an ejection fraction of 31%. Hematology was consulted and GCSF was initiated. She developed coagulopathy and worsening liver dysfunction. Antibiotic coverage was brought in to include meropenem in addition to the vancomycin and the zosyn. And she developed acute kidney injury and pancreatitis as well. At this point, the management of her thyrotoxicosis was kind of very difficult. After several discussions with multiple endocrinologists, including Dr. Power and CHOP, we decided to initiate methimazole, with the caveat being that now that she had been on the GCSF, possibly we can take into account the severe agranulocytosis, and possibly that the agranulocytosis might be secondary to sepsis and not necessarily to the methimazole therapy. So she was started on 20 milligrams and had received 1 dose. We maintained her on SSKI, hydrocortisone, and cholestyramine. Given her recent cardiac event, there was cardiology reported that beta blockade was no longer an option for her. And then later that afternoon, on the first day of admission, we decided to proceed with plasmapheresis, primarily because she was still very hemodynamically unstable. She was on 3 vasoactive medications at this time. Labs were kind of showing kind of continued multi-organ dysfunction. And so plasmapheresis was initiated with a replacement fluid containing 1/3 fresh frozen plasma and 2/3 of albumin. As a reminder, those are her initial TFTs when she arrived to the ED. After the first round of plasmapheresis, her free T4 subsequently improved to 3.68 nanograms per deciliter, and her total T3 also rapidly improved to 281. At this point in time, seeing the profound improvement in her thyroid labs, we decided to discontinue the methimazole therapy and just monitor her response. A second round of plasmapheresis was given the following day. This was primarily under PICU's guidance to help treat her worsening coagulopathy. Following her second round of plasmapheresis, her free T4 further improved to 2.58, and her total T3 is now in the normal range at 193 nanograms per deciliter. After her second round of plasmapheresis, she was extubated about 48 hours post-arrest. Vasoactive support was discontinued around 12 hours following the second cycle of plasmapheresis. She had a repeat echo, which showed improved LV systolic function with now an ejection fraction of 51%. Interesting, later on in her hospital course, she developed persistent hypertension and was started on atenolol 25 milligrams daily by cardiology. She had marked resolution of her coagulopathy, pancreatitis, and AKI in the 24 to 48 hours following her plasmapheresis cycles. She completed 1 week of antibiotics for presumed culture-negative sepsis. And then her GCSF was continued until she had appropriate count recovery in order to safely proceed with thyroidectomy. Subsequently, following her plasmapheresis, we had noted persistently normal thyroid labs. In fact, she was almost close to being hypothyroid prior to proceeding with thyroidectomy with a free T4 of about 0.7 on the morning that she had her thyroidectomy. Cholestyramine, SSKI, and hydrocortisone were gradually discontinued. She underwent total thyroidectomy about 10 days after admission. The primary reason for the delay was the fact that her white count took quite a bit of time to recover. Post-operatively, she developed transient hypoparathyroidism requiring some supplementation, but that had been quickly weaned off as well. On follow-up, she was discharged to a rehab facility due to physical deconditioning following a 2-week admission. She is currently in the 11th grade and doing quite well and has no long-term sequelae of this event or this admission. She is currently compliant with her Synthroid 112 micrograms daily and doing well with that. So in discussion, I wanted to talk a little bit about methimazole-induced agranulocytosis. Agranulocytosis usually occurs within the first 2 to 3 months of treatment. There have been case reports of agranulocytosis occurring after long-term use, and even case reports of agranulocytosis occurring after methimazole therapy had been discontinued. The agranulocytosis is mediated by a variety of mechanisms. There's direct toxic effects by the metabolite with direct penetration into the bone marrow, affecting glucose and oxygen utilization of the lymphocytes, of the neutrophils, sorry. And there's also a mediated destruction of neutrophils. The toxic effects require about 20 to 40 days of exposure with an insidious onset, though it is sometimes can be idiosyncratic, and there have been case reports of methimazole-induced agranulocytosis occurring after just a couple of doses of methimazole. Therapy with GCSF can accelerate neutrophil recovery, but for many people, the agranulocytosis resolves after discontinuation of the methimazole therapy. Therapeutic plasma exchange can be used in the management of thyroid storm. The benefit of that being it can remove TBG, thyroid hormones, the autoantibodies, the catecholamines, and the cytokines from the plasma. It was first used in 1970 for the management of thyroid storm. Since then, there have been about 57 case reports in the adult literature about the management of thyroid storm using plasmapheresis. There has been one published pediatric case report in a 15-year-old female who presented with thyroid storm, septic shock, and severe agranulocytosis. She had also had a history of Graves' disease and was compliant with methimazole therapy at the time of presentation. She required 5 cycles of plasmapheresis and was noted to have bilateral peritonsillar abscesses, which was thought to be the contributing for her septic shock and agranulocytosis. Typically, plasma exchange is used as a bridging therapy to thyroidectomy. The effect on the hormone levels is usually transient, and it's expected that the thyroid hormone levels will rise the following day after receiving plasmapheresis. The type of replacement fluid is either FFP or albumin. FFP is preferred as it has thyroid binding globulin, so it can be able to remove more thyroid hormone, but albumin is more cost effective and carries a lower infection risk. In the US, plasmapheresis is classified as a Category 3 classification for the management of thyroid storm. It's reserved for patients with thyroid storm with severe symptoms in which the first-line therapy failed or cannot be used due to toxicity. The apheresis guidelines in the US recommend a mix of FFP and albumin as the replacement fluid, and typically perform cycles daily to every 3 days for 3 to 6 cycles before resolution of symptoms. In Japan, the Japan Thyroid Association actually calls TPE classification to be used within 24 to 48 hours if the patients are not improving with medical therapy alone. In conclusion, this case, we demonstrated the safety and efficacy of plasmapheresis therapy in the management of thyroid storm in a pediatric patient. This is the first known case that had marked improvement in thyroid function following just 1 cycle of plasmapheresis, with sustained effects noted almost 1 week prior to thyroidectomy. In many of the published case reports, it was noted that at least 3 cycles of plasmapheresis were needed before you saw a significant improvement in the thyroid function labs. And as reported by the apheresis guidelines, that effect is usually transient, and such thyroidectomy needs to be performed quickly, which was not the case in our presentation. I think from this, we can learn that TPE definitely has a role in the management of severe thyrotoxic crisis in a pediatric population that is not amenable and or refractory to medical therapy. Those are my references. Thank you very much.
Thank you, Dr. Youssef. This was indeed a challenging case, and I think this is what all of us as endocrinologists sort of fear when we have patients presenting in Graves' disease. So thank you for outlining the, in this case, the heroic measures that were taken to treat this patient. There's a question about the reasoning for using surgery, so going to thyroidectomy versus radioactive iodine ablation. Can you speak to that in this case?
The main reason that radioactive iodine ablation was no longer considered was because we had already started her on Lugol solution. And so therefore radioactive iodine would not be effective in management for you. And she was quite hemodynamically unstable. And so there was a risk of just not being able to tolerate that therapy as well.
Sure, and a follow-up question to that, at your center, in terms of the decision to go to definitive therapy, not in a case of thyrotoxicosis or thyroid storm, but just generally for patients who are medically managed with methimazole, at your center, what is the typical route to definitive therapy in terms of radioactive iodine ablation or thyroidectomy based on the clinical course?
We have kind of a quite variety of our cases. There are some patients who prefer definitive therapy early on as to avoid long-term methimazole management and the concern for side effects of methimazole. There are quite a few cases of patients who elect to proceed with radioactive iodine ablation, especially if their labs are kind of in that perfect ideal range, and they like the idea of having just permanent treatment of their thyroid storm and of their Graves' disease. And thyroidectomy is obviously also used. I feel like it's not as popular of an option in our patient population as opposed to radioactive iodine ablation. We do perform a lot more radioactive ablations for the management of Graves' disease as opposed to thyroidectomy.
Okay, well, thank you. And what outstanding presentations from Drs. Gennard, Kerr, and Youssef to kick off the day. In a second, we're going to take a 10-minute break and then reconvene at 9:10 Central Time. And please stay tuned. You'll want to be back right at 9:10 sharp because we'll have Dr. Brad Miller from University of Minnesota giving us an update on long-acting growth hormone. And we also have our other two featured afternoon or morning speakers, Dr. Maria Redondo from Baylor and Dr. Todd Alonso from University of Colorado and Barbara Davis Center, who'll be giving updates on the Radiant Diabetes Network for Dr. Redondo and COVID-19 with the treating diabetes during the COVID-19 pandemic by Dr. Todd Alonso. While you're taking your break, I'll remind you that we do have the virtual poster hall on the Pestola website. It should be very easy to find. Once you go to pestola.org, you'll see it. At this time, I'm pleased to introduce Dr. Bradley Miller, who's a professor of pediatrics and the division director of pediatric endocrinology in the University of Minnesota Medical School. Dr. Miller has an interest in the role of growth hormone, IGF system, and normal and abnormal growth in children. He's also interested in growth and development of children following adversity, including cancer and its therapies, fetal alcohol exposure, and international adoption. Today, Dr. Miller will be sharing timely updates on the development of long-acting growth hormone. So Dr. Miller, take it away.
Thank you. Let me share my screen. There we go. All right. Well, thank you to the organizers for inviting me. I have a soft spot for Pestola since I was the Midwest Pediatric Endocrine Society president for a few years, and very happy to see the regional societies surviving and thriving. So today I'll talk about the development of long-acting growth hormone, and you know, my presentation, as was mentioned earlier, was delayed due to snow and ice in Texas. And I talked to Paul Thornton about it, and he said, "What do you guys do with this all winter?" And I said, "Well, we do fine because we're prepared for it unless the power goes out." And so I think that was the huge difference for you guys. And I'm glad it's warming up, and we're above freezing again and expecting 68 degrees this week. So for Minnesota, that's summer. So today instead of last 2 weeks ago. So my disclosures, I am a consultant for a number of different companies developing new drugs for kids, and I will be discussing off-label use of medications since most of the medications I'm describing are still in development. The objectives of my talk today are to understand the barriers to optimal outcomes with our current daily growth hormone therapy and to recognize the potential challenges that new long-acting growth hormone products may pose to monitoring of short and long-term safety and efficacy. And I want to start by saying recombinant human growth hormone has been a therapy available that is working for our treatment of children with multiple different conditions and indications. And you can see the FDA approval for the different indications for pediatric therapy as well as adult therapy that are currently available. And I use the analogy that when you have a hammer, everything is a nail. But the pros and cons of daily growth hormone therapy are that we have more than 500,000 patient years of safety data. And that's definitely the short-term data that's available. And long-term data is still being collected. We have the adult height being near the midparental target height in children with growth hormone deficiency and established short-term efficacy in adults. The cons of daily therapy are that it is a daily therapy. You have to take a shot every day, and that there is a cost to the treatment. The history of growth hormone began with pituitary growth hormone therapy back in 1958 when the first patients were treated with pituitary-derived growth hormone. In 1979, before recombinant growth hormone daily was available, gelatin-based method of prolonging growth hormone action was attempted. Daily growth hormone was approved in 1985. adult growth hormone deficiency in 1996. The first long-acting growth hormone was approved in the US in 1999, and I'll talk a little bit more about that. And then two long-acting growth hormones in Asia, Utropin in 2009 and Jintrolong in 2014. And last year, Sogroya was actually approved for adult growth hormone deficiency. And so I think we can see that there's progress in the direction towards long-acting growth hormone therapy. The growth hormone molecule is 22 kilodaltons, is the one that we see circulating in the blood at the highest level, and that's the molecule that has been used in commercial development of growth hormone. And it binds to the growth hormone receptor dimers via two different binding sites that sequentially bind to the receptors. How long does growth hormone last in the body? Well, it is cleared by glomerular filtration, receptor-mediated uptake, and extracellular proteases. So if you give an injection IV or an IV infusion, it lasts for 14 to 19 minutes. And the half-life of a sub-Q injection is about 2 hours. And so you can see the difference in the clearance by the different methods. But daily growth hormone isn't physiologic. When we think about how are we giving growth hormone therapy now, you basically get this peak of growth hormone with the daily injection that differs significantly from what we would see in the normal pulsatile pattern of growth hormone release, with the largest peaks happening in the early hours of the morning. So the reason for considering a long-acting growth hormone versus a daily growth hormone is that there's the potential for the improvement of adherence, persistence, and the growth response. And it's been stated as early as 400 BC that Hippocrates noted that patients did not take their medications as prescribed, it didn't work. And as C. Everett Koop, who was Surgeon General in the 80s, said, drugs don't work in patients who don't take them. The table below shows different studies that look at the actual compliance or adherence to growth hormone therapy, with a study in the US showing that about 10% were missing more than 15 injections per month, and that there was a height velocity difference in the patients that were receiving fewer injections. A classic study, and this was using an electronic device that was capturing the injections. Classic study in New Zealand by Wayne Cutfield was where the vials were actually returned to the pharmacy and counted. And they also showed that 66% of children missed at least one injection per week. And you could see a reduction in the height in response to that impaired adherence. And so daily injections are hard to remember, and if we could improve that by having them less frequently, it's possible that we will improve the adherence, and hopefully in response to that, the efficacy. The other thing that I said at the beginning was that daily growth hormone, children reach near their midparental target height. And this is a summary of the different phase 4 registries of daily growth hormone therapy, some of which are just United States based and others that are international. And you can see that the starting height at the time of beginning treatment compared to their final height at adult height or near adult height that's available in the registry does not quite meet the 0 standard deviation. And so you can see that they're making significant gains, but not getting to the mean, suggesting that there's some room for improvement in the actual efficacy of the treatment as well. Whether that's adherence or differences in how our body metabolizes growth hormone that might be improved by a long-acting growth hormone remains to be seen. So what are the characteristics that we would like in an effective long-acting treatment? We want it to do everything that naturally secreted growth hormone does. We want the molecule to get to all the tissues that it needs to. We want it to be a small volume and administered with a small needle, similar to the daily growth hormone that we have now. Easy to administer with a user-friendly device, room temperature stable, pain-free, which we'd all like that, but at least incomparable tolerability to daily, and a lack of immunogenicity, because we're actually talking about changing the growth hormone molecule in some way to make it more long-acting, and some of the mechanisms of doing that could change how the body responds to it. So in 2016, I was a member of a group for the Growth Hormone Research Society that looked at what would be the best development approach for long-acting growth hormone molecules. And this society consensus was that the long-acting growth hormone may represent a significant innovation in clinical care, which is essential to be carefully surveilled in long-term studies. So they thought there was promise in the molecules that were being developed, that there was a good reason to have them because reduced adherence to daily injections likely compromises the response to treatment, and that the early data in the clinical trials was showing promise. They also noted that the different long-acting growth hormones have different pharmacokinetic and pharmacodynamic profiles because of the different technologies that make the growth hormone last longer. And so those were going to be specific to each formulation, and therefore how we monitor and see how the medications work and adjust the dose would also have to be unique to each of those molecules. So I also asked the question as, will long-acting growth hormone be superior to daily growth hormone? If we think that daily growth hormone is inconvenient, painful, and has distressing daily injections, leading to a lack of adherence and a reduced efficacy with increased healthcare costs, it's possible that long-acting growth hormone, if it's able to overcome the adherence issues, if the pharmacodynamics are superior with higher IGF-1 levels per dose and superior metabolic actions, then there would be potentially superior to a daily molecule. The non-physiologic profile may be beneficial, but it could also have some different side effects. And so I think that's another component we have to look at. So how do we make a growth hormone injection last longer? First, we can delay the rate of absorption from the subcutaneous space, incorporation into microspheres. This is what we see with depolupron, for example, where the body eventually metabolizes those microspheres and releases the drug. We can reduce the rate of clearance from the circulation and polyethylene glycol, either through permanent pegylation or reversible pegylation is one method. We can modify the growth hormone's ability to bind to serum proteins. In particular, it's been changing how things bind to albumin. Or we could create fusion proteins with synthetic polypeptides or naturally occurring proteins. And I'll talk today about human chorionic gonadotropin, as well as immunoglobulin chain modifications of growth hormone to prolong their activity. And I wanted to go back and talk a little bit about neutropin. As a fellow, I was actually involved in giving the first long-acting growth hormone to some of my patients. And this was neutropin depot that was approved in 1999 that used an encapsulated biodegradable polylactide co-glycolide polymer microspheres. So similar to what I said with Lupron, is that the medication, after being subcutaneously administered, was released from those microspheres in a biphasic manner. You'd have initial pulse and then slow degradation of the microspheres to release the medication as the polymer was hydrolyzed. So in phase 1, they did studies once a month, twice a month, and then once a month at a higher dose. And the phase 3, they did a low dose twice a month and a higher dose once a month. And we can see that in children that received 1.5 milligrams per kilogram once a month, their 12-month growth velocity was 7.6 centimeters per year, and then the twice monthly 7.9 centimeters per year. And I'll talk later about what the centimeters per year comparison is, but this is actually lower than what we would typically see in the first year of therapy with daily growth hormone. We could also see the biochemical profile. So you could see that growth hormone levels decreased over time, making this make the most sense to be a twice monthly medication because of that fall off by 14 days. And then the IGF-1 levels were actually with the twice monthly, the lower dose had a higher peak, and then the higher dose actually, again, at 14 days, you could see that the IGF-1 levels were back down into the pre-treatment range. And this just shows the multiple dosing over time that you could see the IGF-1 levels rising and falling during the profile of the medication. But unfortunately, in 2004, this medication was discontinued. There were difficulties in commercializing the product and manufacturing the product, and so it is no longer available. Next, I want to talk about the discontinued products that have been studied previously and that are no longer being studied. Just for comparison, a number of medications have been tested that have been once weekly. There have been a number of pegylated growth hormones that were discontinued, at least to some degree, because of local reactions with lipoatrophy. Ambrx had actually seen some chorionic villi vacuolization in animal models, and so there were concerns about potential damage from the molecule. And then Teva had been doing a growth hormone fused with albumin, and Versartis, which I had been quite involved with, a fusion protein with 3 hydrophilic nonsense amino acid change. And you can see that each of these have been discontinued. The Versartis trial was in pediatric growth hormone deficiency, given twice monthly, but did not meet their clinical endpoint of non-inferiority to growth hormone, daily growth hormone. This slide actually shows the molecules that are either currently in development or already approved in different locations around the world. And you can see there's a depot molecule, a pegylated molecule, a prodrug, one that has non-covalent albumin binding, and several that are fusion proteins. And today I'll highlight different ones that are currently the furthest along in their development. So this shows that group of molecules in a different way, showing how close they are to being available for treatment in patients. Jintrolong is a pegylated molecule available in China and already has phase 4 studies in more than 3,000 children being conducted with pediatric growth hormone deficiency. They're also studying other indications. Utropin is available in Korea, already being marketed. Transcon growth hormone, or Lonapeg somatropin by Ascendis, has completed their phase 3 trial and filed for FDA approval and is continuing trials in adult growth hormone deficiency. Somapacitan, or now Sogroya commercially, was approved in August for adult growth hormone deficiency, but is not yet available for patients, and their phase 3 trial is ongoing. GXH9 is in clinical trials, and Somatrogon, which has been completed their phase 3 for pediatric growth hormone deficiency and has filed for FDA approval. So I'm going to present each of the molecules with the biochemistry behind it and a few key points as well. So first, Utropin is a depot formulation of growth hormone using sodium hyaluronate microparticles. So basically, suspension in MCT oil, you have a spheroid microparticle containing the growth hormone in this sodium hyaluronate with sustained release of the growth hormone by diffusion. Notably, this is native growth hormone and 22 kilodaltons that's being released. In the phase 3 clinical trials for children receiving the medication once weekly versus genotropin at 0.21 mg per kg per week, you could see that they were growing 11.6 and 12 centimeters per year. So an excellent growth velocity in prepubertal children. They also saw sustained growth over 2 years, which is an important factor that we're continuing to see good growth. And it's fairly typical to see a drop after the first year of treatment to the second year of treatment in growth hormone trials. And you could see that in both the daily and the weekly arm. And they also had similar safety profiles. Gintralong, which is a pegylated molecule prepared by conjugating a branch polyethylene glycol molecule to amino groups on the growth hormone. And this is just showing those PEG structure. It's actually 62 kilodaltons, so about 3 times the size of native growth hormone. Phase 3 trial results for Gintralong in China. These are 6-month data rather than 52 weeks data. So you grow better in the first 6 months than you do the second. So it may be a little bit of overestimating the response. In the Gintralong once weekly, it was 13.4 centimeters per year. And in the daily growth hormone, 12.6 centimeters per year. So an excellent and robust growth response. Numerically, but not statistically superior to the daily molecule. Adverse events were comparable. Glucose and lipid profiles were in the normal range, and no subject developed any anti-growth hormone antibodies. Somapacitan, now trademarked Sogroya, is a growth hormone molecule that has been modified by a single point mutation to which a side chain of 1.3 kilodalton terminal fatty acid with non-covalent albumin binding properties is added, and that binds endogenous circulating albumin. And so the modified molecule is just slightly larger than the 22 kilodaltons by this 1.3 kilodalton addition. This is actually similar technology to what was used in insulin Detmer, insulin degludec, liraglutide, and semaglutide. So it's basically taking the growth hormone molecule, adding this albumin binder chain, which then binds to endogenous circulating albumin. The linker is added to a location that is not involved in growth hormone receptor binding. It occupies less than 0.01% of circulating albumin. And it's important to show that somapacitan actually penetrates the growth plate. So you can see that it's stimulating growth plate activity. It's actually able to be identified, localized in the growth plate. And you can also see that somapacitan activates the growth hormone receptor in a similar way to growth hormone native growth hormone, I should say. So it's showing that it can get to the target where we want it to do its job. In the phase 2 REAL 3 clinical trial, at 52 weeks, there were 3 different doses of somapacitan in children with pediatric growth hormone deficiency. At 52 weeks, 11.5 centimeters was numerically superior to the daily growth hormone, which was 10 centimeters per year. And it also showed similar safety and tolerability to the daily growth hormone. And this 0.16 mg per kg per week compared to the daily growth hormone is what is currently being used in their phase 3 trial, which is expected to finish sometime later this year. So the other point I wanted to make about the somapacitan phase 3 data is that we have information about what happens to their IGF-1 levels. And in the trial, it depends on when you look at the IGF-1 compared to when the dose was given. So at weeks 4 and 13 of the 52-week trial, they were measured at trough. Week 26 was peak. And then there's a model derived average that shows what the IGF-1 was over the course of therapy. And then we have the daily values. And so with the dose of daily, you could see that the IGF-1 raised to the 0 SD, with the somapacitan peak, you could see that some values at peak were, the average was above 0 standard deviation, but some values went quite high, above +2 standard deviations. But the average value was actually slightly above the mean and not exceeding the +2 standard deviations. There were some peaks, as I mentioned, greater than +3 SD. So if we think that IGF-1 peak values are related to efficacy or adverse effects, that's something that we want to be aware of. I'm going to briefly present the adult data because that's what was approved for FDA indication for growth hormone therapy. This was actually placebo-controlled data with once-weekly somapacitan versus placebo and versus daily for 34 weeks with a washout period. Then people switched to the other molecules. And I wanted to present this one to show how the IGF-1 values actually in that extension phase stayed pretty stable in the individuals receiving somapacitan, right at the mean, which is where they're targeting and adjusting for in the adult population. Somatrogon, just have to look at my time here, contains 3 C-terminal peptides, carboxy terminal peptides from the natural human chorionic gonadotropin. And you can see here that there's 1 CTP molecule at one end of the growth hormone and 2 CTP molecules at the other end of the growth hormone, resulting in a prolonged circulatory half-life. And the CTP chain is actually what makes human chorionic gonadotropin last longer in the circulation than LH does. So LH and HCG are very similar, except that HCG has these C-terminal peptides that prolong its activity. So 47.5 kilodaltons, it's about twice the size of native growth hormone. The phase 2 clinical trial data showed a excellent growth response, and there were 3 different doses in the phase 2 trial compared to a single daily dose of growth hormone. And we could see that the growth velocity was similar to daily and the safety was similar. But in 2019, I was going to say last year, but this is already 2 years ago, a year and a half ago now, the phase 3 trial data was released, and then Sherry Deal presented the data at the Endocrine Society last spring, showing that the children receiving weekly somatrogon grew 10.1 centimeters per year compared to 9.8 centimeters per year in the daily genotropin arm. So again, it was numerically superior to daily genotropin with safety and tolerability that were similar. Transcon growth hormone, or Lonapeg somatropin, being developed by Ascendis, is a pegylated growth hormone that involves a transcon carrier, this transcon linker, and the native unmodified growth hormone. And so this is the same 22 kilodalton molecule that we're using in the different preparations currently. This linker is actually able to be cleaved dependent upon pH and temperature, releasing the active native growth hormone that is no longer modified and separating it from the transcon carrier. This transcon carrier is then cleared by the kidney, and the growth hormone is able to interact with its receptor and be cleared naturally. The characteristics of this linker help to determine how long the molecule lasts in the blood, or the pharmacokinetics. And so transcon growth hormone, or Lonapeg somatropin, is being studied as a once-weekly medication. The phase 3 height trial included children receiving Lonapeg somatropin at 0.24 mg per kg per week, same dose as the daily. And these data show that at 52 weeks, these prepubertal children with growth hormone deficiency grew 11.2 centimeters per year on the weekly medication. And compared to the daily genotropin arm of 10.3 centimeters per year, this was both numerically and statistically superior to the daily growth hormone arm. In phase 3 flight trial, this is a group of children that were already receiving growth hormone therapy and transitioned to once weekly growth hormone therapy, as well as a group of younger children that were naive to therapy and receiving once weekly TransCon growth hormone. We could see a growth velocity that was higher in the younger group, as we would expect. And similar to what we would expect in terms of continued therapy responses in older individuals. Important points about this study is that they included children in that younger age group so that we could start to get experience in the younger population that received growth hormone therapy. Important information from the phase 3 flight trial also includes the IGF-1 data. So at baseline, the IGF-1 data, these are kids that have already been receiving growth hormone and their IGF-1 levels are plus 0.9. In response to the transition to Lonapeg somatropin, their IGF-1 levels increased at both weeks 13 and 26. There were a number of children that had baseline values that were between +2 and +3 standard deviations, and a few that were greater than +3. And at week 13 and week 26, measuring post-dose day 5, when we should see an approximate average of the IGF-1 levels, there were still some elevations in the IGF-1 values in some children. However, it's important that there were, most of them were in the normal range, and there were no IGF-1 related adverse events that were seen in the trial. And I think it's also important that as we think about long-acting growth hormone and the IGF-1 values, we don't really have a value of IGF-1 above which we think that there's a safety, a negative outcome related to that value. So I think it just helps us recognize what are the values, when should we measure them, and how do we use that for long-term safety and adjusting our medication. And I think that we need more information over time to help do that. Last molecule that I'll talk about is in development in Korea and China. So phase 3 has been announced to occur in China soon. It's a long-acting growth hormone fusion protein with a hybrid of immunoglobulin D and immunoglobulin G4, which could make this once weekly or every other week dosing, and is a 100 kilodalton molecule. Their phase 3 trial that they did in children with pediatric growth hormone deficiency, looking at different doses compared to daily growth hormone, both weekly and once monthly, twice monthly, showed growth in those children that was similar to the daily group. But interestingly, there really wasn't a dose response. We don't see higher doses getting better growth in this molecule. There are two molecules that I've talked about today that are significantly larger than native growth hormone, and there are some questions as to whether those larger molecules will reach the target tissues. And so I think that remains an unanswered question that we need to look at over time. It's important because the growth hormone molecule is conserved through evolution in terms of its size. And the size of a molecule may determine its ability to penetrate the growth plate where it needs to do its job. And this came up with the Versartis trial because the drug was about 5 times the size of native growth hormone at 119 kilodaltons. And there was an increase in BMI in the children that were in the clinical trial, that the data that was reported. And there was a question as to whether we were getting a IGF-1 effect of the treatment, but not a growth hormone treatment. And so I think that's an important question that was raised by Paul Sanger at the international meeting in 2017. So to summarize, I think we have for long-acting growth hormone therapy, We know that recombinant daily therapy requires daily administrations with adherence that has been suboptimal with frequent dose omissions and treatment cessation. We know that our efficacy in terms of adult height still has some room for improvement. There have been a variety of technologies to prolong growth hormone actions. None have been approved yet in children. As I mentioned, Sogroya was approved in the US just last year, but is not yet available for adults with growth hormone deficiency. There are a number of growth hormone preparations that have been discontinued due to the lack of efficacy or an adverse safety profile, or even the Neutropin Depot, which had manufacturing or commercialization challenges. Whereas these new preparations are still currently undergoing clinical trials or have completed their trials and are awaiting FDA approval. Because of the variability of the PK/PD of the different long-acting growth hormone preparations, we have to have a strategy for monitoring and dosing therapy that's going to need to be individualized for each preparation. But I want to point out that like other hormone replacement therapies, long-acting growth hormone preparations induce a non-physiologic growth hormone profile, and so does daily growth hormone for that matter. But our evidence thus far has not shown that it compromises overall treatment efficacy or safety. And I think that the data from our studies suggests that long-acting growth hormone preparations hold promise for achieving clinical efficacy while maintaining a good safety profile. But I want to implore the companies and the regulatory agencies to encourage long-term safety surveillance studies to improve our understanding of the prolonged exposure to these different non-physiologic growth hormone profiles. I think we still have a lot of questions of how the longer acting growth hormones will compare to daily, and we still, after 35 years, have questions about daily growth hormone and its long-term safety. So I think it's an important point. So as I mentioned, those concerns include the metabolic, cardiovascular, and neoplasia concerns. There was a recent study from the SAJ group, or actually, I apologize, from the Swedish group that looks at potential increased risk of cardiovascular events that had been prompted by the SAJ data, and a need for additional study to help us understand whether cardiovascular events are more likely in patients who have received growth hormone as children. Are they because they receive growth hormone, or are they because of the condition for which they require growth hormone therapy, is still open question. We don't yet know what the requirement by the regulatory agencies will be. As I mentioned earlier, why are we studying long-acting growth hormone as non-inferior? That's an FDA pathway to approval, but I'd actually like us to get better results. And I think that I already mentioned we need long-term follow-up and how these medications work. There's still some practical implications. How do we adjust the dose? When should we monitor the IGF-1 for both safety and efficacy? I mentioned earlier that there are different times when you look at the IGF-1 that give you more information. Well, our patients show up when they show up. So we need to know when they took their last dose. And I think that we'll see ways of calculating an average IGF-1 for each of the molecules. Will anti-long-acting growth hormone antibodies impair growth? So far in the clinical trials, we have not seen that in the ones that are currently being developed. There was some speculation that that occurred in children in the Versartis trial, but unfortunately those data were never published. Will lipoatrophy be a side effect? I think it will, because it is with daily growth hormone if you keep using the same spots, but these molecules are mostly a depot in the blood rather than a depot in the skin. So I think it's less likely potentially than the earlier long-acting growth hormones. And then I think, how will these potential therapies be incorporated into the care of children? The biggest thing for me is whether or not insurance will cover it, and whether that is going to make it available to our patients. So with that, LAGH, auf Wiedersehen, goodbye, hasta luego, la rivedere. I open to questions and thank again the organizers for inviting me to, for the presentation. As always, even if we don't grow right, we are still perfect. Our patients, even when they're not growing, they're still awesome. And I want to acknowledge Kevin Yuen and Eric Velasquez, who were my partners in publishing the long-acting growth hormone review in JCM last year, and share some pictures of Minnesota. I didn't show any snow, just in case you were wondering.
Well, thank you very much, Dr. Miller. And there's a lot of excitement from the audience who are speculating that this long-acting growth hormone could really represent a breakthrough in clinical care, both in terms of the ease of administration as well as the efficacy, but of course, taking into account the risk of side effects that you alluded to and monitoring those carefully and long-term over time. We're going to ask you for a second to take a look into your crystal ball. There are a few questions about the timing of if and when you see FDA approval coming down the pike. And also related to that, what do you perceive as any issues with cost and coverage once indeed it is potentially approved?
Well, I think those are both really important questions. And I've been a clinical investigator in the studies of each of the molecules that are coming towards approval and consult with the companies. So I have to expose that and share that. But I think the important thing to know is that the FDA process is the FDA process. We don't really know what to predict there. The PDUFA date, which I don't even know what that means, but that's when the FDA is supposed to say whether or not they approve a medication. For Ascendis's Lonapeg somatropin is in June. So I think if they are given a green light, we could see growth hormone available sometime later this year and potentially the fall. For somatrogon, they have submitted their data to the FDA in early 2021. And so my expectation is, since it's a 10-month clock, that they should hear sometime in late 2021. And if they get a green light, then we would see medication in early 2022 is a guesstimate. For somapacitan, now Sogroya, I'm not entirely clear when their clinical trial will be complete and when that data will be available and submitted to the growth hormone or to the FDA. And so I think that one has a little bit longer timeline from when we'll see it. From a cost perspective, I think it's a huge and important question. Because I actually did participate in some early economic discussions in Europe related to long-acting growth hormone, because most payers, whether it's US or governments, aren't interested in paying for convenience. If the recognition of these long-acting molecules are literally that they're just less often and that there's no other benefit, it may be difficult to convince the payers that this is worthwhile. I think, as I've already mentioned, that particularly in kids, there's a big difference between convenience and burden. A shot every day and versus a shot once a week is a huge difference for kids. You know, when I talk to families about daily injections and I say this could be weekly, there's like a big sigh, like, oh my gosh, thank you. That would be amazing. And so I think there's some transformation in that decrease frequency that's more than convenience. But I'm also hoping that we can show that adherence will be better and outcomes will be better with treatment, and that will be enough for the regulators or insurance and government payers to say this is worthwhile. Will it be more expensive than daily? Probably, because it's a lot of money to develop a new molecule, a new drug. but I don't know that it'll be a lot different. And but that's it's the billion-dollar question. Really, is will it be covered? Will it be more expensive? Will it work as well? And I think those are key questions coming soon. I actually have a clinical trial at my center looking at how kids do during that transition, trying to look at quality of life, adherence changes, body composition changes. So we're geared up and ready to see how they do as they make that transition.
Thank you. We have a couple questions coming in about the utility of long-acting growth hormone in special populations. For example, I think it's probably Dr. Paul who asked, have there been any early studies examining the prevention of hypoglycemia in young patients with growth hormone deficiency in the setting of panhypopituitarism?
No, actually, that's a key population to discuss. And actually, I'm more afraid that the long-acting molecules will not be good therapies for that young population. We don't have any data in that population yet. The Ascendus flight trial that I mentioned went down to age 3. Somapacitan, I think, was 2.5. And I apologize, I can't remember if the lower age for the somatrogon study was 2.5 or 3, but we don't have any in the super young. And as you could see briefly when I showed the pharmacokinetic profile of the different molecules, if you have a molecule that's due to last 7 days, and we think that the benefit on hypoglycemia is growth hormone amount, then your growth hormone levels are going to trough at some point. They're going to be at a nadir where that child may be at increased risk of hypoglycemia. If the difference is your IGF-1 level or some other change that the growth hormone causes that has a slightly different profile, IGF-BP1, whatever we think that protection against hypoglycemia is, then there may be some benefit in those kids. But I'm worried because of the peak trough that they might actually not be good candidates for avoidance of hypoglycemia. But I'm interested when the molecules are available to do those studies carefully with CGM, et cetera.
So we have a question about the potential for long-term safety issues and whether or not you think there might be a difference between long-acting growth hormone versus the traditional daily growth hormone in terms of the potential for long-term safety issues.
So as I mentioned in my presentation, that is still an open question. I think that there's going to be a brief period for each of the molecules where your growth hormone levels and your IGF-1 levels are supra normal, if you will. They're above the normal range for varying amounts depending upon the dose and the child's response to the medication. I think the key value that we want to focus on is actually the average IGF-1. I'm not sure that those short-term exposures to high values have a negative impact. We haven't seen that in children on daily growth hormone. But it's still a question that remains to be studied in the long term. But my perspective is that I don't think they're going to have a different short or long-term safety profile than the daily, but we need that information. Metabolically, there's the same question. I had this conversation with someone who's a metabolic specialist in the past, and he says it's so non-physiologic, the growth hormone, you've taken away all of the growth hormone pulses, whereas with daily, you at least are giving a pulse. And so if there's a benefit of those metabolic pulses on your body composition in the long term, you're actually taking that away and could have negative effects. That said, the adult outcomes that are in the somapacitan trial are all metabolic, and they saw good responses in terms of fat composition changes that were the endpoints for the trial. So in the adults where the metabolic outcome was the endpoint, they did see positive effects. So it's still going to be a challenge to answer that question with 6-month or 1-year trials. I think we need more long-term experience.
Great. Well, thank you so much for joining us at Pestola and taking the time out of your busy schedule to meet with our group. At this time, I'd like to present Dr. Maria Redondo, who's a professor of pediatrics at Baylor College of Medicine and the director of Texas Children's Hospital's Diabetes and Endocrinology Research Program. I must say, she's taken our research program to new heights with her leadership, her vision, and her ability to mentor fellows and junior faculty. Dr. Redondo's research focuses on type 1 diabetes genetics and atypical forms of diabetes. She's actively involved in the ADA Precision Medicine and Diabetes Initiative, where she chairs the T1D diagnostic group. Today, Dr. Redondo will be presenting on the innovative work of the NIH and IDDK funded Radiant Diabetes Network. So Dr. Redondo, welcome.
Thank you very much for the very kind introduction, Daniel, and thank you very much for allowing me and inviting me to present today to you and the Pestola committee. So today I would like to talk to you about the Rare and Atypical Diabetes Network, or Radiant, and so as clinicians and also as researchers, we are all familiar with these cases of diabetes where we are not clear the type that we are facing. This is very frustrating to us, not only because we are primed to really want to know what people have, but also because it really translates into uncertainty in terms of the best clinical management. It is also frustrating for patients because that uncertainty translates to them, and they feel that we don't really know exactly what type of diabetes they have, and they fear that maybe the treatment is not the best possible. So with that background, the NIH funded the Rare and Atypical Diabetes Network. So here today, I will go over the objectives of Radiant. What do we mean by atypical diabetes? I'll present a brief overview of the study, and then I will explain to you how you could refer patients if you would like. So the objectives of Radiant are to identify patients and families with atypical forms of diabetes so that we can characterize the underlying molecular mechanisms. So we have a stated commitment to reach out to minority groups and underrepresented populations. So at every step of our process, we are incorporating processes that will facilitate that goal. So we will perform genetic and phenotypic characterization of these participants. We will construct a biorepository and database, and we hope that those that data and biosamples will be available to the scientific community to advance research in this area. So we would like to make new diagnoses, describe new types of diabetes, new molecular mechanisms, and for those atypical forms. And also we think that some of those atypical diabetes mechanisms actually play a role in the more garden variety type of diabetes. So we think that we will also help with the more common forms of diabetes, just with the typical type, where still there are many mechanisms that we don't really know well enough. So what do we mean by atypical diabetes? So today, particularly not just focused on the pediatric population, but overall, the most common type of diabetes that is diagnosed is type 2 diabetes. Type 1 in general is thought to represent less than 10% of the cases. And then we have a group of other that includes gestational, drug-induced, pancreatogenic, then secondary types, monogenic diabetes. But we do recognize that there's heterogeneity within type 1, within type 2, and overlap between the two, and then a number of cases that really do not fall easily into any of those established categories. So atypical diabetes. So it has really taken us as a group for the Radiant study almost 2 years to kind of come to a consensus of what atypical diabetes is. Each of us have an idea of what that looks like. And so, so we really are defining atypical diabetes here in a way that will allow us to really discover new genetic variants underlying rare phenotypes within known categories, or describe entirely new phenotypes and genetic variants outside those known categories. So we are planning to do so with deep phenotyping of individuals and families, and then with whole genome sequencing. With this, I'm saying that sometimes we feel that a typical patient, really, even if it is atypical, might not be completely what we are looking for, or the other way around. This is how we have defined it for this reason. So how are we planning to find participants for Radiant? So there are three main sources. Number one is established registries. So many of the people who came together for this network had already an interest in atypical diabetes and had a established registry. For example, the monogenic diabetes registries in Chicago or Maryland, the lipodystrophic diabetes registry in Michigan, the ketosis-prone diabetes registry in Baylor, and other registries. We are also planning and starting to mine electronic health records using criteria that will allow us to capture that atypicalness that we are looking for. And as anyone working in this area, with all the caveats and difficulties to do so, but we are making progress in that area, and that will definitely be a very important source. And then the third is actually very important. So those are individual referrers. So people are referred by clinicians like you who see atypical cases. Also, we are taking self-referrals from patients who feel that they have atypical diabetes. So what are the inclusion and exclusion criteria? So let's go first with the exclusion. So we are not interested in that has a high likelihood of being a known type of diabetes, such as typical type 1, typical type 2, or even solved cause of rare causes, such as known monogenic diabetes, known lipodystrophic syndrome, known Wolfram syndrome. Of course, an exception to that would be unusual presentations of those rare causes. We are not taking pregnant women because of their inability to do some of the testing that we will need to do, but of course they can join later. And then of course refusal to consent for genetic testing, that is one of the mainstays of what we'll be doing. The inclusion criteria will be having a high likelihood of rare and atypical diabetes. Some of the examples are type 2 diabetes diagnosed in prepubertal age, or thin type 2 diabetes, a very clear Mendelian pattern of disease with early onset in the pediatric age, for example, syndromic, non-progressive in a setting where you would expect a progression such as type 1, or rapidly progressive in a setting where you would expect slower progression such as type 2. Very low insulin requirements in a setting where you would not expect that. Cyclical diabetes with periods of remission, and then lean PCOS or lean gestational diabetes, and also ketosis-prone diabetes, for example. There are a number of Radiant centers and clinical sites. So the genetic cores are in the Broad Institute and the Baylor College of Medicine in Houston, and the metabolomics core is at Duke University. Besides that, we have a number 14 actually sites across the United States that will house those patients in terms of doing their phenotyping and consenting and those study research activities. And of course, Baylor College of Medicine and Texas Children's Hospital is one of the sites that is in this area of the United States. I would like to introduce to you the Radiant team at Baylor College of Medicine, Texas Children's Hospital. So in the adult side, Baylor College of Medicine Adult Endocrinology, we have Dr. Ashok Balasubramaniam, who is also one of the study PIs, Dr. Rushi Gawa, Dr. Jennifer Posey, and Mary Fang. And then on the pediatric side, Texas Children's Hospital, I am the pediatric site PI, Dr. Mustafa Tosur, Dr. Stephanie Sisley, Dr. Marcela Astudillo. And then the study coordinator is Erica Hattery. So I would like just to give you a very brief or kind of big scale overview of the study protocol so that you kind of know a little what is going to happen. So on the top of this screen, you have the three sources for patients, the atypical diabetes registries, the ketosis prone diabetes, for example, or the monogenic diabetes registry in Chicago with unknown unsolved cause cases. We have the individual patient referrals in the middle, and then we have the diabetes cohorts and databases, which at this point basically refers to the electronic medical record datasets. So those patients will, those potential cases will go through stage 1 consent, with the participant goes online and themselves answer the questions. So it does not require a research coordinator or someone to do that. The participant actually does that. They complete a questionnaire, and then there will be some autoantibody tests that will be done through a Quest kit that I will explain to you later. So that is what we call the stage 1 consent. That information is reviewed by what we call an adjudication committee. And we, in the adjudication committee, we look at the questionnaire, the autoantibody results, the medical records, all of those, that information, and then we determine whether that participant looks eligible for Radiant and ready to move to stage 2. On the other hand, we may decide that is not eligible, or that we require more information, or there's actually even another bucket of patients that we are calling keeping reserve. Like, we find it might be interesting, but at this point is not our main priority. After that comes, oops, sorry about that. Okay, I hope that you are seeing my screen, something, okay, there. So stage 2 consent comes next. At this stage, we get a sample, blood sample for DNA and RNA instruction, and that's where we will do the whole genome sequencing. If there's no known diabetes variant, the participant will move to stage 3 consent. In this case, we'll have a clinic visit for physical exam, OGTT, metabolomics, and other tests that might be needed, as well as RNA-seq. That information will be then reviewed by the discovery team, where diagnosis, characterization, possible assessment of family members are considered, and then additional optional phenotyping is considered as well. So from a participant perspective, stage 1 will include questionnaires and blood collection. It undergoes the adjudication committee review. Stage 2 will include an optional visit to the study center, blood collection, whole genome sequencing, then discovery team review. And then stage 3 will include physical exam, standard phenotypic testing, and then additional deeper phenotyping testing and RNA sequencing. So recruitment at the stage 1, the very first stage. So all the recruitment sources will keep going through asking the participants to join Radiant on the public website. That is regardless of a recruitment method. All of the participants will enroll via the public website. So we advise the potential participants to go into the website and enroll themselves. We have online consent, online questionnaires, and then a kit is mailed to the participants to go to Quest for autoantibody testing, and those results are sent to us, and then we communicate with the participant. Because of our interest in reaching out to underrepresented participants, we also have another route where we can actually do paper, and we have our research coordinators who can help with that process, because we've been recognizing that some participants actually do not have an email address or do not have really easy access to internet. So this is our main venue, but we do have another possibility when that is needed. So then once the adjudication committee accepts a participant, they are assigned to a local site, and then they proceed to stage 2. So at this stage, a local study coordinator, which usually is selected by the participants. So they say, I live close to the Texas area, so I want to go to Texas Children, so I live close to Chicago, so that's where I want to go. So a local coordinator at that place reaches out to the participants, describes stage 2, and schedules a visit. That visit can take place remotely with remote consent, again with a collection kit that is sent to the participant, and they go to Quest and to get the blood drawn. Or we are also allowing an in-person visit with in-person consent, sample collection, and investigator encounters. We have both routes. Then we have the genetic team review, the discovery team review. And then going into stage 3, again, we have a local study coordinator that reaches out to the participants. This time we need a visit in person, fasting, and then we have in-person consent, sample collection, OGTT, and then a detailed radiant-oriented physical exam. This is just to show you a little bit our thinking on how this is going to work. This is a very busy slide, but just to, the main message is that this is we are envisioning this as a very iterative process where we, after that collection of data that I just described, we might be able to diagnose a novel syndrome or identify a cluster that might require additional testing, or that on the other hand, we don't see any novel syndrome, so we might need additional testing or not, and then we'll go that process until we really consider the case finalized. We are definitely planning to share our data, and regardless of the decision of the case, so that is beneficial for the scientific community. So I thought it would be interesting to give you some examples of atypical diabetes candidates, in this case from established registries. For example, we have a participant referred from the Chicago Monogenic Diabetes Registry. This is a 32-year-old non-Hispanic white female that was diagnosed with gestational diabetes at the age of 24 with a BMI of 20. So this patient was thin, was asymptomatic, but failed the OGTT and was in treatment with diet. So autoantibody negative stimulated C-peptide was present, and then there were no really any other relevant medical history. So currently the participant is still within the thin or within the normal weight with an A1C of 7.2 on insulin as well as non-insulin agents. There are some family history of diabetes in the father who was diagnosed with type 2 diabetes at age 53 when was overweight. And then a sister with type 2 diabetes in their 40s, overweight, no treatment, and then the paternal grandfather with diabetes at unknown age, but definitely before 60 when was deceased. So clearly some family history of early type 2 diabetes on the paternal side. The genetic workup that is done by the Chicago Monogenic Diabetes Registry includes, say, type 1 diabetes genetic risk score. That is a genetic combination of the genes that are associated with type 1 and that has been proven effective at identifying or helping make that decision on the diabetes type. And in this case was low, meaning a low genetic likelihood of autoimmune type 1. So the Chicago group did next generation sequencing of a panel for monogenic diabetes that yielded negative results. So overall, this is a patient with gestational diabetes without really a known cause. So no obesity, no insulin resistance, no autoimmunity. So why does this person have diabetes? And fairly comprehensive study of monogenics by Chicago determined no cause. So this is a good patient for Radiant because we are hoping to find another looks like genetic cause that is aligned in the paternal side of the family that is causing the diabetes of this woman. So the next case I would like to present to you comes from the Ketosis-Prone Diabetes Registry in the Adult Endocrinology Group at Baylor College of Medicine. To do so, I would like just to briefly introduce you to the ketosis-prone diabetes concept. This was presented by, developed by Dr. Balasubramanian, who in the ketosis-prone diabetes identified 4 groups: beta cell function positive or negative versus autoantibody positive or negative, and described 4 groups to develop this ketosis-prone diabetes syndrome, and was able to identify some phenotypic characteristics that were really distinct in those in those 4 groups. And then further analysis with deeper phenotyping and genetic analysis was really able to find some etiological causes of some of these cases. So with that background, this is a 42-year-old Hispanic man who presented with DKA, had been diagnosed with diabetes 9 months ago, briefly of metformin, but then switched to insulin, although not taking it. A1C was high at 11, BMI was right at the 25th mark, and was negative for antibodies, with a relatively low C-peptide despite a high glucose, and then the peak of C-peptide after glucagon was 0.1. So was classified as autoantibody negative, beta cell function negative, ketosis-prone diabetes. So, so that's an interesting patient because we don't have any additional information on what can be causing that person to have DKA with no autoimmunity, no beta cell function, but no apparent cause for that syndrome. So now let's move on to how do we refer patients to Radiant. So participants can just go to the public site of Radiant. We find it a little bit more effective because one has to make the case for why their diabetes is atypical. So with experience that we are gaining, we find that it's actually easier if we help them kind of review the case and say, yeah, we agree, this is atypical, this is how you should present it. So if you are inclined to do so, please engage with one of us, Radiant principal investigators at any of the sites in the country. You have on the screen my email. You are very welcome to email me at Texas Children's Hospital, Baylor College of Medicine, with your potential cases of atypical diabetes. Physicians can also go directly to the Radiant website and find site contact information for other sites, and you have there the website. We can give you flyers and brochures to provide to offices to distribute to interested patients. You can, if you're interested in collaborating with us on an ongoing basis, please contact me or any other PI on the study to see how we can do it. At this point, because of how the NIH funding works, we don't have ability to include new sites, but as you all know, NIH will issue new calls for these grants, so hopefully we'll be able to add new sites. So that definitely is open for the future, we hope. And we are definitely committed to giving credit to everyone who is involved in this effort, including those who refer clinical cases. So with that, I would like to finish thanking you for your attention, and I will be very happy to take questions from you all.
Well, thank you, Dr. Redondo. And speaking as someone who's used Radiant and referred patients there, I can say it's so helpful. I think we all have these sort of dilemmas where there might be either mixed phenotype or we have a suspicion for MODY or something else that either we can't get testing or it comes back negative. So it's great to have Radiant as a resource for those patients. To that end, there are some questions about MODY testing. Is MODY testing required prior to referral to Radiant? And then also in those cases where insurance doesn't cover MODY testing, would it be appropriate to refer those patients to Radiant?
Yeah, that is a very good question, Daniel. And we are really trying to figure that out, right? So ideally, we would like to have MODY testing through clinical routes. It makes sense from a clinical standpoint to rule out diabetes first. So the first idea that we had was, yeah, you need to rule out MODY as, with the panel that we have clinically available. We are finding that, just as you are mentioning, that actually may impair our ability to recruit that, in particular, actually, that subset that we really want to study because they have been understudied in the past. So people who have less access to an appropriate insurance or things like that might be at a disadvantage there. So we do not want to have that as a barrier. So please do not let that be a barrier for referring those patients. We appreciate if you guys can do on the clinic, and make sense from the clinical standpoint, right? But like I said, please just let us know. We are actually working on establishing a contract with a company that's the MODI testing through a different route. So we are trying to find a formalized way to do that. But in the meantime, we are definitely not considering that an exclusion criteria at all.
Another question, during the COVID-19 pandemic, have you seen an increase in rare and atypical forms of diabetes, perhaps in the context of SARS-CoV-2 infection or just presenting during the pandemic?
Yeah, that is a very good question that we really want to answer. We have not started analyzing the data. So we have actually been quite successful getting referrals. We have a very elevated number of actually over 400 participants who have been referred to Radiant are right now at different stages of the process. We are getting ready to launch what we call stage 2. Some patients have reached that stage and we are getting ready to do those. So with that, I'm saying that we don't have those data yet, but we are definitely, that's one of the things that we are very curious about.
Another question, for patients who reach that stage 3 for Radiant, where they're actually going to a study center for the physical exam, the OGTT, and further testing, is there reimbursement or coverage for their travel if they're coming from a different site?
Definitely, yes. Yes, definitely. We are planning to reimburse that. Yes, that we have. I mean, there's set aside some funds, and we really want to make that not a barrier, which can be for precisely some of the participants that we want to have.
Outstanding. You mentioned that there are flyers and brochures that could be available to some of the clinics. How would they go about getting those? Are they available directly from the website, or can they reach out to you or perhaps a research coordinator?
So far, please reach out to me, or I mean, the research coordinator, Erica, has those brochures and can send them to you guys. But just for easy logistics, please reach out to me and I'll be very happy to put you in contact with Erica.
Got it. So what do you perceive as you're studying this group and underlying the association of genotype to phenotype and elucidating more and more about these rare and atypical forms? What impact do you think that will have in terms of the management for those patients and perhaps improving clinical outcomes long-term?
Yeah, so monogenic diabetes is really the prime example of precision medicine, right? So that's our dream. So monogenic diabetes, when it's due to a known genetic cause, in some cases can be treated with, as we all pediatric endocrinologists know, with a particular therapy that is more effective and safer than what you would otherwise do. So that is exactly what we want. And that's, we are hoping that will happen with those new monogenic diabetes cases that hopefully we'll discover, but also we really think that that could be actually underlying some of the pathogenesis of the more typical cases of type 2 diabetes, but have those genes maybe contributing with a smaller effect, but they could be leveraged for treatment as well. So we are hoping that that will make an impact not only for those participants with rare cases of diabetes, but would also shed light on the more common types of diabetes in terms of therapy. So our ultimate goal, of course, is to improve the lives of those people with diabetes in general and be able to use precision medicine.
Another question, with so much emerging around genetics and disease phenotyping and perhaps treatment with precision medicine, do you foresee a future in clinical care where the genotyping might be a part of just actually routine care, whether that's a risk score or perhaps whole exome sequencing? What are your thoughts on that?
I completely, that is my personal dream. So actually, as some of you know, so one of my research projects funded by the NIH that is just starting is actually trying to see whether the genetic risk score, the type 1 diabetes genetic risk score, can help us understand what type of diabetes are pediatric patient has. So as a clinician in pediatric endocrinology, I'm faced many times, and I think that many of you guys, at least, you know, that we work together. So, you know, obese kid with one antibody, what do I do, right? Does he have type 1, type 2? And most importantly, do I need to give insulin or not? Am I going to find them in the ER next month if I don't do insulin? So that is that picture, which I have to say has been really hard to fund, because I think that in other places they were not seeing it, and now we see it, and I think that in other parts of the country is becoming more common. So we think that the genetic risk score is another piece, of course not the only. We'll have to use antibodies, HAT presentation, and BMI, and of course all of those clinical markers, but genetics. An advantage of genetics is that it doesn't change with time, as we find that happens with C-peptide, right? You measure C-peptide at the beginning, but you know, DKA, then later on, so many, but genetics is permanent. And the other thing is that it can be acquired at onset, while the traditional way of solving those cases is wait and see if the patient develops DKA or their A1C goes up to the roof if I just do metformin. So we think that that is not ideal. So we want to use genetics at the onset of diabetes as another piece to classify diabetes type in children. So that I would personally love to do that, and I'm you know, very excited about that project.
And, you know, we're doing that with the autoantibodies now. So maybe that's what the future will hold with the genetic testing as well. Exactly. Speaking of the diabetes autoantibodies, now that it might be actually commercially available for patients who aren't actually presenting with diabetes, what are your thoughts on that, and what our role as an endocrinologist and diabetes care team might be in patients who have positive antibodies?
Right. So you are talking about screening for type 1 diabetes risk in the general population, right? Yes, completely. So I am personally very excited about that. I think that the latest literature showing that we do have effective and safe therapies to offer those patients who are at risk for type 1 diabetes. We've had a predictive model for type 1 diabetes for many years that is, you know, if anything, has shown to be very precise. So we can be quite confident on that model. And now we have a therapy. So the natural next step is that. So as you may know, many of you, in Colorado, the general population screening has been piloted for a while, and it works. And it will happen in the rest. And I know that some organizations are planning to fund that effort. So we as pediatric endocrinologists are going to be faced with that, right? So patients from the general population, not even within a research study, out of the street, and they present with positive antibody. So what do we do? So I think that we need to be ready to become familiar with those preventive treatments that some people will want, and you know, some of them have received preliminary approval by the FDA, so it's going to happen. So I think that's I have to say, I think that will be a challenge for us that are not used to that, to manage, you know, using those therapies. But I think that the data is there, and definitely the affected people are very interested in that. So I'm very excited about that as well.
Awesome. Well, speaking of Colorado, our next speaker will actually be from University of Colorado and Barbara Davis Center. So Dr. Redondo, thank you so much for that excellent presentation on the Radiant Diabetes Network, and for really providing a clear outline of how our collaborators from other institutions can refer patients to the Radiant, either through the website or reaching out to you, research coordinators. I'm hopeful that this will generate some, you know, interesting patients who can be worked up for the rare and atypical forms of diabetes. I'd like to introduce our final speaker, Dr. Todd Alonso, who has deep Pestola roots. Todd is a Texas native who grew up in Fort Worth. He attended medical school at UT Houston, pediatric residency at Texas Children's Hospital, and pediatric endocrinology fellowship at Children's Medical Center in Dallas. Since fellowship, Dr. Alonso has been on faculty at the University of Colorado, at the Barbara Davis Center for Diabetes, where he serves as the Assistant Medical Director for Quality and Access. Dr. Alonso's academic interests involve the intersection of clinical workflows, quality improvement, and EMR data. He has several leadership roles within the T1D Exchange Quality Improvement Collaborative, where we've gotten to know Dr. Alonso very well and learned a lot from the work that he and his team at Barbara Davis Center are doing. Among his many roles, he serves as the co-PI on the COVID-19 surveillance registry, and that's one of the things we'll be presenting on today. So Dr. Alonso, welcome, and you're up.
Thanks, Dan. And I'm sharing my screen now. It's been a few weeks since I did this preview with Daphne, so I hope I'm doing it right. I hope you guys can see okay. But we're going to talk about COVID-19 and type 1 diabetes in children. And I have no conflicts of interest. And so the objectives for the talk today, just to give you kind of an overview of where we want to go. We want to talk about kind of how these risks are different in adults versus children with type 1 diabetes, because the profiles really do look a little bit different. I want to talk about what risk factors may increase the risk for children when they experience COVID-19. And we want to really get to the practical piece. You know, as a guy who is really involved in quality improvement in my clinic, the hat that I'm usually wearing is, how can we do something that's better for our population? So not just about doing the research, but actually bringing improvement in. So I want to kind of get there at the end and maybe challenge you guys to think about what you're doing in your clinics now and what you're doing through COVID and what you're going to be able to do for next steps. So let's start with an overview here, kind of taking a step back and thinking about infectious disease in people with type 1 diabetes. So we know, and there's lots of good data, and if you go to the ISPAD statement, there's a lot of individual articles that are cited. We know that adults with type 1 are more likely than adults without diabetes to have infections of all sorts of places in the body. So urinary tract, skin and soft tissue, lower respiratory tract, and pneumonia, serious bacterial infections requiring hospitalization. So the evidence is really, really clear when you look at the adult data. But then when you look at children and adolescents, and certainly those with A1C at or near target range, it's a lot harder to be able to identify what that risk would be. Do children with type 1 diabetes have more risk of getting infections and getting sicker with infections than their peers without diabetes? That's a really hard question to answer. And so probably the best answer that we have is maybe they do, maybe it's like adults, but the effect is nowhere near as strong in children as it is in adults. And then of course this audience, I know you guys have taken call, and you know that when we go through RSV season and flu season and we see other infectious diseases, we know that can trigger diabetic ketoacidosis. So those are our thoughts in mind as we enter into the pandemic era and we think about what's going on in our population. We learned really early on from China when they began publishing some adult data and then later pediatric data that healthy children are susceptible to COVID-19, but the rate of illness and severe illness and death is far, far lower than in adults. So for comparison, in a normal year with influenza, we would see maybe a little over 100 deaths in pediatrics and tens of thousands, maybe 50 or 60,000 deaths from influenza in adults. Compare that with the last year in the United States, we have over 500,000 deaths in the US, but only about 250 deaths in children. And then when we think about the minority communities, and this was really evident in New York back in April, that the minority communities were hit a lot harder by the COVID pandemic, both in terms of the number of people and the percent of people who got COVID, as well as how ill they were when they got COVID, because we know underlying health in those communities is a lot poorer at baseline. So these are our concerns. High A1C, that is a risk factor for our patients for getting more ill. We know that our minority patients have higher A1C, they have higher risk of diabetic ketoacidosis to begin with. So now as COVID enters, these are the questions we're left with, and that's kind of what I've been asking the last few slides. So I want to look over some peer-reviewed studies. This is an article, I think this is really interesting. We have 21 reports on COVID and type 1 diabetes. And this article was just e-published, I think, back in December or January. And so here we are, less than a year into a pandemic, a completely novel disease, and we already have a review article with 21 reports, which I think is just absolutely amazing, and just shows us how quickly the science has moved in the last year. And so they broke this out into several groups because these are our areas of question. So among people with pre-existing diabetes, how ill are they? What about those with new onset or newly diagnosed type 1 diabetes? And then questions about outpatient management. So there's sections in this article. So if you do go pull an article, I do recommend this is a really good review to give you kind of a high level. And so these are some of the papers here on the right side that I think these are all 21 that they reviewed. And just an overview on the left side to hit these quickly. We know that people with pre-existing type 1 diabetes who got sick with COVID, they very often present with hyperglycemia and DKA. We'll talk a little bit more about that in the data when we get to it in the next few slides. When we look at hospitalization rates, that is like reasons for hospitalization and the cofactors for like BMI and age, that really mirrors what we see in the general population. So older patients, heavier patients, people with underlying illnesses were definitely a lot more likely to be hospitalized. That's not very surprising. The new onset rate appears stable. And we're going to dig into that data just a little bit, but DKA may be a little bit more common at onset. And then there's been several papers talking about glycemic control, especially during the lockdown periods. And it's really unclear. I think more of the papers have said that glycemic control looked a little bit better, but some suggested there was maybe no change. And it probably really depended on the geography and the health system and the group of patients that they were looking at. So I didn't want to dig into that paper and into those papers because it's a little bit all over the place. So two of the groups that have given us really some of the best data for population level are this group from the UK, Holman, was the first author on this paper. They have a couple papers. And so I want to look at that one first. So they had over 250,000 people with type 1 diabetes in the UK. And this is, I think, around 64 million people whose data were in this national database. And among those, there were 464 deaths due to COVID among those over 250,000 people. And you can see the risk factors and the hazard ratios here on the right. And in France, so this was a network of several dozen hospitals and clinics. There were hospitals because they looked at hospitalized patients with type 1. And there were 3 deaths among 56 people with type 1, none of the deaths in people under age 55. And this was just during a small window during the spring. But you remember that the France and the UK and Italy all had really high rates of COVID early in the spring before the US peak. And so because the N was so much smaller in the Coronado study, you can see the odds ratios really do cross over 1 and very few are significant. But at least in the Holman paper, unsurprising and based on what we know outside of type 1 diabetes, we know that males were more likely to be very ill. And this was the primary outcome for death here. So more likely to die. Patients who were older, that was a really strong risk, higher BMI, higher A1C. Previous MI was not significant, at least in this analysis, but previous stroke was for increasing risk of death. Then this Barron study, this was the same group. And so rather than comparing risk of death in these patients compared to the previous years, is what Holman did, they had 61 million people. Again, very similar number with type 1, over 250,000. And that is about 38% of them were under age 40. They also had another 41,000 with some other forms of diabetes and nearly 3 million with type 2. And during this window, what they looked at March through mid-May, so it was just a 72-day window, they had 23,000 in-hospital deaths due to COVID-19, and about a third of them were in people with diabetes. And so when we look at the data tables here, you can see, this is the good news, bad news slide. So as the pediatricians, it's good news when we think about our patients because I see under age 50, I also did the math for that. That was over half of the patients with type 1 in the study. And yet they had so few deaths, they could not report a death rate per 100,000 here. They didn't give us the absolute number in the paper but they had to data censor because the number was so small. But under age 50, there were very, very few deaths. It's very encouraging. So that's the red box there. But then for the adult endocrinologists who are thinking about those older patients with type 1 and type 2 diabetes, so that would be the second column and the third column compared to the first. And you can see that when we get up to patients in their 50s, 60s, 70s, and beyond, number one, the risk of type 1 diabetes, a death in type 1 diabetes rises very steeply, even more steeply than what we see the rise being in the type 2 diabetes population. So much higher risk of death among the type 1s who are much older. And there's another visualization in this same paper, which we're going to get to. I think that's on the next slide here. But I also wanted to look at the coronary heart disease, cerebral vascular disease, and heart failure. And you can see, again, higher risk of death in men, heart disease, cardiovascular disease, and heart failure all increase the odds of death. And this was not surprising at all. And of course, the association with age was also not a surprise. In advancing, this is the slide that I really like to look at here because we all want to write that paper where we have a graph that doesn't need much explanation, right? And I think that that's what we see here. You can just kind of take a look. So the red section being, or the red lines in the error bars being those with type 1 diabetes, which you can see again, they filter that data and they're not showing us the death rate among those under age 50. But the red line is up top here. So that's the highest number of deaths per 100,000 people, goes up very steeply. And then the type 2s, that's the dark blue with the squares, that's the next line down. So definitely higher than the general population or those without diabetes, being the purple on the bottom line. So certainly when we look at the population, people 50 and above with type 1 and type 2 diabetes, the risk is higher. So the CDC, in making recommendations for the COVID vaccine in the US, has said type 2 diabetes is a risk factor that we should prioritize those people. In the state of Colorado, JDRF and our local foundation have actually advocated with the state in the phase that we just entered yesterday for COVID vaccination and the phase that we'll enter in a few weeks. We'll prioritize people with type 1 and type 2. And I think this is really good based on this data. This is probably the best that we have, looking at a really large population of patients and identifying that, yes, those older adults with type 1 have at least as high of a risk, probably higher risk than those with type 2. Now, when they took the model, and I'm not showing the data here, and they just filtered and looked at those under age 70, the risk was even more profound. So the type 1 versus type 2, you can see those odds ratios 6 times and 3 times higher than the general population. And among their ethnic and minority groups, this is the way they categorize them in the UK. The effect of diabetes was stronger. So those people with diabetes who belong to these minority groups had even higher risk of death. So why is this going on, right? Because, as a pediatric endocrinologist, I usually have a message of hope for most of my families that I take care of. And I tell those families, I expect your child to do well. I expect this at diagnosis, hopefully to be the last time the diabetes puts your child in the hospital. It's going to be hard, and this isn't true for everybody, that they can stay that healthy, but I really do expect you to do well. And we generally think of our patients as being very healthy. So why, when they get so much older, are they so much higher risk? And the only thing that I can think of is maybe it's an effect of having had diabetes for so much longer, so that the obesity and hypertension and hyperlipidemia that are more prevalent in the type 2 population are not strong enough risk factors to overcome the fact that the type 2 patients at this age have been living with the disease for a far shorter amount of time than the type 1s at this age. But this is really interesting data, and I'm really glad that Colorado has prioritized those with type 1, and I hope more states will follow suit with the vaccination prioritization. So again, jumping back to the Holman paper, so they had, like I said before, they compared 2020 deaths and during that time window to the 3 previous years. And again, you can see here the age is the strongest risk factor. So very consistently across data sets, with and without diabetes, age is a very, very strong risk factor. And then you can see minority race, Black and Asian, those don't cross the one line here. So you can see those hazard ratios are increased significantly. And then really importantly, I wanted to show here, we haven't looked at A1C yet. In the National Registry data, it's a little bit harder to get things like lab results in A1C, but they were able to pull that here. And then in the dark blue, you can see I've translated their millimoles over to percents. And it looks like they're, not only is it significant over with an A1C over 10, but it looks like there may be a dose response here. So sort of an effect. So this is another paper that I want to show, and this is US data. We don't have a lot of great data from the US, and this is probably the best done study because what they've done here, this was a group out of Vanderbilt, and you notice if you look through the names, there's no pediatric endocrinologist on this paper, and that's why I'm going to point out a little bit of a caveat, because I think they took their data and extrapolated a little bit more than I would be comfortable with looking into in the pediatric group. But they had over 6,000 people without diabetes, 273 with type 2, and only 40 with type 1. But these are people who definitely had COVID-19. When you think about your own clinics, think about this. We had 137 clinic locations here in Vanderbilt, and they had 40 people with type 1 that they know had COVID-19. How many of your patients have had COVID that you've been tracking? I can tell you at our center, it's well over 100 by now that we know of, and there's a lot more that we don't know of because they have to tell us and we don't necessarily receive those lab results. So the number in my mind is pretty small there, and I would love to see this type of analysis redone with more data. But the adjusted odds ratio for hospitalization and for greater illness severity was higher among type 1s compared to the general population. The risk was similar. I didn't show that for type 2. But again, not only were there not very many type 1s, but only 8 were under age 18. There were no deaths in the type 1 group. Mortality without diabetes was similar to some of the national numbers that we've seen. And mortality in the type 2 group was definitely higher than the general population. So if we had a much higher number of people with type 1 on the order of maybe 200, 300, 400 patients maybe would see a similar mortality trend the way we did in the UK, but we just don't have that N here in the US. But again, this is one of those pretty graphs that we would love to draw in our papers. And of course, this is really interesting. We've got these regression lines. So type 2 patients in blue, the age effect is very strong, starting really by age 20 and going up to older adulthood. And the risk of hospitalization is very much higher, clearly in the type 2s compared to general population, and it's very age-related risk. And then among those without diabetes, this really mirrors what we've seen in other papers across the US and across the world. The risk for hospitalization is very flat, very low risk until we get over age 40, and then it really starts to steeply climb. So that's why, of course, that we're prioritizing these vaccines for older adults. And a lot of states are going from 70 to 65 to 60 with the rollout. And this really makes sense. But I'm really concerned about that red box area there on the left side. 8 patients under age 20, and we're continuing this regression line from adulthood all the way down to the pediatric years. Not only am I a little bit concerned about that, but also about the message that this sends. So when people with type 1 get hospitalized with COVID, what is it? At least in our population nationally that we've looked at in the T1D exchange registry, 75% of those are DKA. So with how strong is that risk, and what message are we sending to our patients? So just in the interest of time, I'm gonna skip through this slide here, other than just to say that absolutely yes, age and diabetes status were really strong risk factors. Race also appears as a risk factor here. So I mentioned the T1D exchange registry, and so if you're familiar with the history, or if you're not, I'll give you a little more background. So the T1D exchange clinic registry was begun just over a decade ago. It's a network of about 70 sites across the US. And these are endocrinology clinics, and many of them associated with hospitals, but not all. But we recruited patients for this clinic registry. And so when you think about what patients we're recruiting, it's definitely the very best picture of type 1 in the US. When you look at the T1D exchange data, right? These are patients who we recruited, and we know who gets underrepresented, people who don't show up to clinic, and people from minority groups, people with more social distress, right? Because are you going to recruit them, or are you going to have them talk to the social worker today? That's probably what you'll do, is spend less time with the research assistant. So that's the first thing. So that's the T1D exchange clinic registry. Now there's a QI group, and Dan alluded to that earlier, and I know several of your hospitals are involved, but for those who are not as aware of the work, we have over 30 sites now across the US, adult and pediatric clinics, with the focus primarily being not on research first, but on being best practice sharing and quality improvement. And so we are collecting whole population data from our clinics and sending that into the dashboard, and so that we can talk about our best practices and our trends across our clinics. And we are being able to put together some research papers, but really with the first focus being on looking at best practices. So we invited clinics from the clinic registry, and additionally to the clinics who were in the QI registry, and we put together this COVID-19 registry this year, and we put out a few papers. This was our inequities paper, and as I look at that author list, you can see we have another Pestola alumnus with Kathy Sumter. She and her group joined us. I'm glad to have them involved, and I know the Texas Children's and Children's Medical Center Dallas groups and Cook Children's as well have all joined us in that. So as we look at this data here, you can see that our non-Hispanic Black patients versus the non-Hispanic white patients were much more likely to be hospitalized versus those who were not hospitalized. So adults and peds, type 1 with COVID, hospitalized versus non-hospitalized patients. And absolutely, there's no question that there's an ascertainment bias. Those who were not very ill at all, we were very unlikely to find out about. And maybe our Black patients are less likely to tell us they got COVID, or maybe less likely even to get tested if the illness was mild. But it does look like they, at least among the ones we know about, our Black patients were much more likely to be hospitalized. And even after you've accounted for race, A1C does still play a factor here. And so that was significantly different, significantly increased with higher A1C, but the effect was not as strong as some of the other risk factors. This was one of the other papers we did. So we actually did look at whole population of those who were newly diagnosed with diabetes. I'm sorry, this was the adult paper. I'm sorry about that. I'm jumping ahead of myself. So this was the adult paper. So we split off the adults and looked at them. And just to point out that, so we had about 58 patients who were hospitalized. Again, it was around half and half hospitalized versus non. And we know that there's a lot more people with COVID-19 who don't get hospitalized. So big ascertainment bias. But what were the reason for hospitalization? DKA, right? There were 5 deaths in the adult group. And those deaths, those tended to be very similarly reported to when you look at the non-type 1 population. So severe respiratory distress. There were no known pediatric deaths. I can tell you that. In our registry, we've had 2 patients in the pediatric cohort, and that paper's in review right now, but we have about, I think there's 230, 250 patients in that paper currently. Only 2 were mechanically ventilated. There were no deaths. There was one 19-year-old who in New York back in the spring had a suspected COVID illness, but she was unable to get tested and she passed away. And she had a lot of other risk factors that, really speak to, some of the things we need to think about for our patients. But she was minority, she was homeless, she had a smoking history and a lot of DKA admissions. So she had lots of risk factors, but is not included in, I don't think she's included here because this was people just with confirmed positive COVID. In the fully adjusted model, A1C was higher risk for hospitalization. And that makes, of course, sense, right? Because when we're looking at DKA being the major risk, the major reason for hospitalization, of course, it's higher A1C. Race, again, just like in the inequities paper that we showed, and pre-existing cardiovascular and kidney disease also increase the risk. Of course, those comorbidities we don't see as common in our population in pediatrics. So we were not able to see that same effect in kids. So I'm showing a little bit of papers, a little bit of data from the Margaret Davis Center. This is unpublished, but we've been tracking our data here. And I think the most important thing, to point out is I have asked our staff repeatedly, when you have a patient who tells you, hey, we had COVID, we tested positive, document that in your record like you would. I do ask our staff to go ahead and document any symptoms the patients report as a part of the medical record when they're seeing the patient, and then forward that to me so I can track them in a spreadsheet. We're also receiving data from Children's Hospital, that's our partner, clinic partner, and we receive that data in the EMR. We have a statewide health information exchange, so other centers that are using medical records that are connected. So even those centers who aren't on Epic, that's our medical record, but we're able to receive those tests. And what we find is we had, this data I think was from maybe late December. I haven't gone back to revise this yet, but what was really striking to me was, we had about 50 confirmed tests. We had about another 40 patients that were self-report only. We did not receive the test at all. So how many of those other patients are out there who have been tested positive and just haven't bothered to tell us because we haven't seen them in clinic since they were ill? Because a lot of these families didn't even bother calling us when their child was ill because they didn't have high sugar or ketones. But we have had 10 episodes of DKA. 6 of the 10 had A1C that was as high as the DCA could read. 9 of 10 had last A1C over 10. There was one whose A1C was, I think, in the low 8s, and that family did call several times for some help. Only 3 of 10 were on CGM, whereas our clinic population, we have about 70% of people on CGM, only 2 of 10 on pump. We have about 65% on pump. And then only 2 of the 10 were non-Hispanic white, and yet that's 77% of our BDC population. So, our Hispanic, Black, and more than one race, those patients accounted for almost all of our DKA events, which is really the face of what DKA looks like in our population to start with. We did have one episode of severe hypoglycemia, and I'm going to show you, this kid's slide, and you can see last A1C at 10.4. Apparently after that visit, he went home and actually started receiving insulin. That's the only explanation that I have. I really wish they would have called us because, right, you look at this 2-week data download, and if you're like me, you're scratching your head saying, where was his severe low, right? Any day in the last 2 weeks, it was a setup. It was somewhere here, I think, in the top. It might have been that Sunday there, but I really can't recall which day it was, and it doesn't really stand out. I think it was on Thursday. He did have a long stretch around 5 o'clock in the afternoon where he was really, really low on here. But you can see that this is a patient who spent way too much time below 70. And just like you, our clinic staff would have jumped all over this if we had known. So clearly he's at really high baseline risk. So I think that COVID-19 itself is probably not a very strong potentiator of severe hypoglycemia, maybe in the setting of illness and not wanting to eat. Just a note about the rest of the DKA cases. I've read through all of those notes from the hospital and from the chart and from the phone calls that the people made in that were charted. And in most of those cases, DKA was COVID-19 was incidental to the DKA. So no fever, no loss of taste or smell, no respiratory symptoms except maybe in a couple of cases trouble breathing, which might have been small respirations, no O2 requirements for almost all those patients. And when they were in the ER, they were found to have COVID-19. So this really isn't different from those patients at baseline, I don't think, who really weren't taking their insulin and they're behind, and maybe the infection pushed them over the edge, or maybe they would have had DKA even without COVID. So let's shift gears a little bit and let's talk about newly diagnosed patients with type 1 and COVID. These were really good questions that our basic science colleagues have brought to us. They said, SARS-CoV-2, this virus binds to that ACE2 receptor that can enter endocrine cells. It's expressed on beta cells. We know during the SARS epidemic from, 15 years ago or so, that there was a really high incidence of hyperglycemia. And early in the COVID-19 pandemic, we started seeing a lot of hyperglycemia, and our adult colleagues talk about patients they've cared for that have just been absolute insulin sinks in the hospital. So this is a really good question. So we also know viral infections really do appear to trigger autoimmune diseases. Some viruses have been implicated in the genesis of type 1. So are we going to see more type 1 diabetes? Are we going to see people with hyperglycemia that gets diagnosed with type 1 that maybe they don't have antibodies? Are we going to have more patients with DKA who are more severely ill at presentation? There could be a few mechanisms, both with like what's going on on the molecular level in the body as well, so maybe it's a different phenotype, but maybe during the stay-at-home orders and with decreased access. We know that children's healthcare really did suffer a lot in the springtime. So this is a paper our group did a few years ago, and if you're familiar with Colorado, we have the population of the greater Houston area, about 5.7 million people, in the whole state of Colorado. We're the only academic medical center in the state. We now have a combined program with Children's Hospital. They do have a separate endocrine clinic that's not under Barbara Davis down in the Colorado Springs, but we do share data with them. So they came online in late 2019. So their data is not shown here. But when if somebody asks you what's the rate of diabetic ketoacidosis among children in the U.S. who are newly diagnosed with type 1, Search is the registry that most people will quote their paper, and even their papers published in the last 2 or 3 years. If you look closely at when that data was collected, it really was collected like 2008, 2009. And so our group several times in a few papers, and this being the most recent published, has shown that the rate of DKA at onset really has risen over the last 20 years. And this was the purpose of this paper, was to look about, during the individual mandate period under Obamacare, where we would have expected more children to be covered. If anything, we actually expected to see the DKA rate fall, and that was not the case here. The privately insured patients had a very steep incline from traditionally around the mid-30% to nearly 60%. And we looked at the 2018 and 2019 whole year data, and it hovers around the mid-50s. So it didn't shoot up more over the last few years, but it's much higher than what we had seen traditionally, what other people quote. So every time I review a paper where they quote the search data for the US DKA rate, I ask them to cite our paper instead, or at least consider citing it, even though it's only single center. We are pretty much the whole state of Colorado. We take care of about 90% of people with type 1. So there are a few papers out there. A couple of these come from I can't believe they got this published files from Australia. They have, in 2020 and during that February to May window, 58 patients who were newly diagnosed. No increase in newly diagnosed diabetes, with a trend towards more DKA, but the p-values you can see on the far right are not significant. So 0.3% in DKA. In London, this is not all of London. This is multi-center regional data, but this is Northwest London, looking really most of April and May, with a little bit of March and June. Only 30 patients with new onset type 1, with an 80% increase, but I have trouble taking it to the bank because it's such a low in. 70% with DKA, that's interesting. That's higher than you would expect. The UK data is probably, I expect it to be somewhere similar to the US, or maybe even a little bit better. So that's a lot of kids with DKA, but again, 80% increase incidence, I'm scratching my head a little bit. Now the Italians do a really good job. They have a national registry, their ISPED Society. I forget what that, I think it's International or Italian Society of Pediatric Endocrinology and Diabetes. I think it's what it stands for. But their proportion of patients with severe DKA was increased from 36% in 2019 during this time window in the spring to 44%. So they had a significant increase. And patients with DKA overall, there was a the percentage was similar to the previous year, 41 versus 38%, not an increase there, but more people with severe DKA. And then when we want to talk pediatric registry data, boy, the Germans do a good job. They've been doing great Tech 1 work since the early 90s with the DPV registry. And that encompasses DPV, if you're familiar, is Austria, Germany, and Luxembourg. And we know that the incidence of type 1 is increasing at about 3 to 5% per year. We know that data from lots and lots of countries, anywhere we have good enough data from. And so Germany's not different. And so that's the regression line. The predicted incidence per 100,000 patient years is the nice blue line. And then that 95% confidence band is on either side. And during the spring window, the number of new onset patients in Germany was very much in line with what was expected. So far, looking at these three here, the London data with just that N of 30, I'm not too interested in, but with hundreds, and I think it was 500 and some patients here, was 531 is where it's labeled on the bottom right. I think this is much larger N and much easier to take to the bank. That there doesn't seem to be a higher incidence of type 1 being reported yet. But that's a question that's going to be out there. So this was the DKA paper that I had jumped ahead of myself on. So T1D registry, T1D exchange clinic group, QI group, 17 sites reporting new onset patients, those who had COVID versus those who didn't have COVID. Overall, the DKA rate at onset was 63%. So that's higher than what we had in Colorado. And that's the highest number that I've seen from a US paper. So certainly really concerning to have seen this during the spring and summer. This was, I believe, through August. I think this was April through August, the time window we looked. Yeah, there it is at the top. Have to remind myself what the dates were, because I think that really matters, right? Because in April and May, we were locked down, we were washing our groceries, we were afraid to go, or maybe not all of us, but some of us were afraid to go for a walk even outside on a sunny day when there was wind. But by August and September and beyond, the world resumed being a little bit more normal, and the access to healthcare really changed during that period as well. So really high incidence of DK here at onset. And look at this. There were only 7 Black patients. Had new onset diabetes. Every one of them had COVID. All 7. And again, I don't know. I mean, the p-value is small. It's a small n, but it does raise my eyebrows and say, gosh, this really speaks to what we know. Compared to the white patients, 75 had a negative COVID test and only 3 had a positive test. So very different there. And the Hispanic patients, also statistically significant, 10 with COVID and 26 without. So again, really concerned about our minority communities. So back to those questions we asked, are we going to see more type 1 diabetes because of SARS-CoV-2? There's no data to support it yet. But then if you've talked to general peds friends, what are they saying? Some of my friends have said, I used to see 7 or 8 otitis media cases a day. I see 2 a week now. The peds ENTs are saying very similar things. I used to do dozens of myringotomies a week, and I do 1 or 2 a week right now. So, that we're going to we have a massive change in pediatric illness. And, I talked about the flu data. We had usually, what was it last year, was 120 some pediatric deaths across the US, if I remember that number right. Only 1 so far from influenza this year. So massive decline in infection. So any risk change could be increased because of COVID, but could be offset and could be decreased because of the fewer other illnesses that our kids get. What about increased severity at presentation? Yes, at least during the lockdown period, because we don't have data that's published after that period. Our group is resubmitting a paper and trying to find reviewers who are aware of the fact that we don't have any data. We don't have any good data from the U.S. I think looking at large numbers other than the T1D exchange group, but we also don't have any data post lockdown period. So reducing the risk for kids with type 1 during the pandemic. This is the practical stuff that I wanted to get to. So I wanted to talk a little bit about some of the things that our group has been doing this year. And some of this is work that we had already been doing pre-COVID, but it became just so much more important during COVID. So this is a 2-pager. We use the Epic electronic medical record system, which I think many of your hospitals do. I know this is possible with other types of record systems like Cerner. But we took this idea. We said, this was a couple years ago, excuse me, asthma action plans are wildly successful because it's a simple plan given to kids with asthma at every visit. And what do you do when you're sick? And we know it decreases hospitalization rates and ER visits among kids with asthma. And it's really analogous to what we have with type 1, right? You know, we have kids who need to take a medicine every day. If they don't take their medicine, they could wind up in the hospital. They could have intermittent exacerbations caused by illness that could make dose changes in their medication be very important. So why can't we translate that to diabetes? Now, we're not dealing with just peak flow, but we're dealing with ketones and blood sugar. So we went to the ISBAD statement and we looked at the table in there on sick day management. And if you haven't looked at it recently, I invite you to pull that out next time you get a chance and see if that table is something you could actually hand to a family and they could unpack. It was way too complicated, in my opinion. It's good for you and me, but definitely not a patient-facing type of material. So we took the recommendations there, and what we baked in was, you know, what's a low-dose glucagon, thanks to Texas Children's and Maury Heyman and all the work you guys have done over the years. I remember, seeing those. And so, what would your dose be? So this would be for a fictional 7-year-old child. So it would be 7 units. I didn't highlight over on the left, but you can see 7 ounces of fluid per hour, because that's a recommendation that at least at our clinic gives 1 ounce per year of age up to, I think, 18 or 20, and then it caps out. And then in the medical record, what we built several years ago was the ability to enter reported basal dose and bolus dose of insulin. And so you can, of course, pull that off the pump. You can put in self-reported numbers, and we all have those patients with an A1C of 12 who report 2 units per kilo per day. And you and I know those are maybe aspirational doses, but they're not actually being received in most cases. So we had to build some safety filters in here. But what we calculated was 5, 10, and 20% of your total daily dose based on the recommendations from ISBAD. And then the safety filter that we built in was, if the reported dose was greater than 1.5 units per kilo per day, revert to a 1 unit per kilo per day dosing paradigm. So we were able to build all of this into Epic. And I'm giving you this nauseating detail to tell you that, yes, this can be done. And I'd be happy to connect you with our analyst and show you some of what we did, especially for those of you who use Epic. You'd have to rebuild it in your system. You can't just copy paste. When we look at this, I still feel like it's too wordy, and I'd love to keep it simpler for people, but this is what we've been able to boil it down to. On the back side, you can see we have some more tips about sick day, and then in blue, you can see the hyperlink. That's for the VDC homepage. We put together a sick day video a few years ago. There was a young woman who worked on our team who I think now is a PEDS resident down in Texas. Some of you guys should find her and recruit her to your fellowship program, but she did a really good job. She's a young woman who lives with diabetes. And so I put her on this and said, I want you to create a video and put this together for us. So she did a really good job putting this together for us, and we've re-recorded it a few times. But we have about a 5-minute video that people can access. We show this in clinic. We show this periodically to patients, and then we really did buckle down on sick day management this year for our patients. And yet I think we still need to rename this plan, because some people say, well, she wasn't sick. Well, she wound up in DKA. She was sick. So maybe we need to call this the Prevent DKA plan, or make sure you don't have ketones plan. I don't know. We need some kind of other name for it. So I'm going to talk a little bit about the T1D exchange group. So the QI collaborative, well, the idea is for us to share best practices, and for us to have rapid small tests of change, and then to be able to share those ideas, and we can know and we can learn from one another. What did you do? Gosh, that's a good idea. We should do that in our clinic. How did you go about doing it? What worked? What didn't work? And then what did your data look like? And so we put together a working group a few years ago, and we just published this Access to Care clinical package a few months ago. One of my team members helped co-author this. So they did a really good job putting this together. But the idea was, regular follow-up for patients. And so some of the big things that we took away, that the clinics who were being successful, was when patients check into clinic, that's where you need to ensure that they have their next follow-up already scheduled. We do know that that's a challenge, and some people do walk out of the building without their next follow-up scheduled. What about for patients who don't have follow-up? We've for a long time taken the approach that if you want to see us, give us a call. That works for some people. That does not work for our high-risk families, and does not work for some of the people who are more disconnected. So we actually have a few team members who spend time reaching out to families, both via email or portal message, or even phone calls, and we get variable rates of response to those, as you can imagine. We've created different appointment types. It's, you know, at several of our clinics said, you know, I can't just put these short notice follow-ups in just any appointments type, but, you know, I need maybe a DKA follow-up appointment, or a, you know, even if I can't get you in with your preferred provider today, I can get you in to see your nurse today, and we can at least have somebody sign off on the chart. We need to develop transition programs. That's some ongoing work. And then, of course, 2019 or 2020, we really launched a lot of home telemedicine. And, you know, how do we do home telemedicine well? And I know that you guys have all dealt with that in the last year. But so that we had the sites, we got together in early 2019. We learned a lot from Cincinnati Children's, who had really been some leaders in this area. They put together a key driver diagram. They had already piloted some changes, and we said, why do we want to redefine loss to follow-up any different from what you guys have already done? You've had a working group get on this. We took their definition just straight out of what they had done, so we could compare data, but also that saved us a meeting right there, because they'd already made the decision and it made sense. So we had these rates of loss to follow-up that had kind of hovered, and you can see there was a rise. It looked like in late 2019, but really it's this pattern throughout the year where we kind of fall through the summer, and then we rise in the winter, and then we fall in the summer again. But when we really started working on this, and this is all of our data together from, I think, 4 or 5 sites that were able to contribute data, we had a really steep drop in the loss to follow-up rate. And the way we formally defined that was patients who hadn't been seen in over 6 months, who had no follow-up on the books. And so these are some of the interventions that we had put out here on the right. So by developing reporting within the medical record, patient outreach, targeted outreach to patients, MyChart, that's our portal on Epic, email, phone calls, new appointment types, and then scheduling follow-up during visits. So those are some of the things we talked about. And the last thing, increasing CGM use. I'm not going to go into too much detail on that, but some of the work that we've done is we have created an optional CGM class for patients who do the new onset 1-week class. So what our new onset paradigm looks like is day 1 and day 2 is doc, talk, and nurse, and then social work and dietitian on day 2. The day 2 has been via Zoom for most of our patients in the last year. And then we used to do the 1-week class in person, and we have turned that into a Zoom class now that most people attend. And then we do a Spanish version and a toddler version about once or twice a month. But one of our physicians was really passionate about getting patients on CGM early, and she said, I want to put together curriculum. So we made it optional. It's about 20 or 30 minutes. We tag it on to the end of the 1-week class, and we tell people, if you want to log off, fine, but we would encourage you to attend this class and learn a little more about CGMs. And we found that by introducing that conversation really early with these families, the uptake has really shot up steeply. Colorado is one of 11 states that does not have a formal CGM policy. There is an early prevention and treatment program, I think it's EPTSD, I think that's the abbreviation, where so that you can get CGM coverage, but you have to find somebody in your Medicaid office in your state Medicaid office who will sit down and work with you. It does take, we do this work, and it does take these patients almost a month to get a CGM, whereas private insurance is about a week. So it's definitely a heavier lift, and we are continuing to advocate to break this barrier down. But this is something that nationwide, at least patients up through age 18 should be able to get CGM if they're on Medicaid. And we just got a $70,000 grant from Colorado Medicaid to provide CGM for some patients. And I just talked to one of the young women on our team who leads that, and we've given those out in the last couple of weeks. We've identified 17 patients who are on the hybrid closed loop that uses the Dexcom CGM, and so we've been able to put that in their hands so they can use that fully hybrid closed loop. And we're going to be moving on to other patients who are not necessarily on that, but these are patients who are I think over 21 now, who cannot get any coverage from CGM. So now we found a way for them to get coverage. We're tracking that, and we're going to prepare that data so that we can go in and advocate even more strongly to Colorado Medicaid that, you know, these are patients that you gave us money to take care of, and look what we were able to do. And then we made sure to collect a lot of free text because that's going to be in the advocacy piece. And some of the comments were things like, this is better than Christmas. So I think that one's going to be number 1 on the list when we hand that back to Colorado Medicaid. So just in the last few minutes, and I saw a couple questions jump through, and I'm not savvy enough to be able to click on those and look at them during. So I'm going to hit these last I think I have 2 or 3 summary slides, and then we'll hit some of the questions, Dan, if we have some time there. So the risk of adults versus children. So adults over age 50, clearly higher risk than than children. Children with type 1, DKA seems to be the biggest risk. We did have one patient about MISC in the T1D exchange registry. And again, that's over 250 people with type 1 in children who got COVID. So it's a really low number, but what's that rate look like compared to the general pediatric population? I don't think there's any clarity. And then severe illness and death in children with type 1, no real increase in risk. But DKA being the big risk, high A1C leading to DKA, that's a known risk factor from all the registry studies. Our Black patients, and to a lesser extent our Hispanic patients. And then the hypercoagulability, I didn't touch on that, but that was the death we had in New York, was an apparent pulmonary embolus. So we know COVID-19 potentiates a hypercoagulable state. Hyperglycemia leads to dehydration. That leads to hypercoagulability. So in our patients who are dehydrated and hyperglycemic, I do worry about that in some of our patients. So some of the plans, what can we do to reduce illness in our kids and reduce the severity of the pandemic? So sick day, regular follow-up care, CGM, and of course primary care access, because that's the BDC data that it didn't show you. We have it in submission now that after the lockdowns were lifted, our DKA rate did trend back towards normal trends towards previous years. But when we didn't have good primary care access during the spring, that was definitely a really big concern. So that's the end of my slideshow. I'm going to stop my screen share, and then maybe I'll be able to see some of the questions.
Yeah, and Todd, thank you for that great presentation. Very comprehensive overview. And it's been so amazing to see how fast the science has moved during the COVID-19 pandemic. We learned so much. One of my takeaways from your presentation is it seems like we still have a paucity of data for the T1D pediatric population, both in terms of the implications for new onset and severeness of presentation in DKA, but also complications of COVID-19. Whether it was the UK study, which had the mortality rates didn't actually go down below 50, or the Vandy study, which you outlined, they sort of extrapolated based on a very small sample size. I've had sort of a similar experience of what you've described, which is, and we probably had more cases of COVID-19 in Texas where schools have been open for a while, but in the vast majority of cases, they've been very mild, either asymptomatic, and that's been true for my patients with tight glycemic control, moderate glycemic control, and poor glycemic control. What is your sort of thought or gestalt, based on the limited data we have and your clinical experience of what this overall will show? I'll tell you what I normally counsel families is that children with type 1 diabetes appear to respond more like kids without type 1 diabetes than they do older adults with type 1 when it comes to COVID-19. Is that, do you think that's accurate? Should we change how we counsel? What are your thoughts on that?
Yeah, and Dan, you know me, I don't speak in absolutes to my family. So I'm just really transparent with them that exactly like you said, there's a paucity of data. So the term I've been using is measured reassurance. I think you've probably heard Osagi use that before, that, I'm reassured by how well our kids have done with COVID. And I know that there's been a lot more COVID in the type 1 population, both in our clinic, because I've tried so hard to track that, as well as nationally. I know other clinics, we've reported so much data in, and really very, very few patients have had the COVID-y outcomes, right? The severe respiratory distress. And once, if you take out the DKA, which looks like it's really, I feel like in those cases, having reviewed those charts, the DKA, it's almost like it was going to happen anyway, right? These are kids with high A1C who've had repeated DKAs, and then COVID seemed incidental for them. So if you were to take that out, the risk of hospitalization with COVID in the pediatric population appears to be very, very low. And of course, when we get to really low numbers, both in the general pediatric population, very low numbers of hospitalizations and death, and then similarly in the peds type 1 population, when you get to really low numbers, I can say to families, I think your overall risk is very low. Having type 1, your risk might be a little bit higher, but that's still a very low risk. So it's kind of like the conversation of relative and absolute risk, where, even if it were a doubling, it's still a very, very low number. And of course, to be clear, I don't think it's a doubling of risk. I don't think we have that clarity of data. So I have measured reassurance, and I see families just like you guys do that have been keeping their children home and doing homeschool throughout the pandemic. Other families who have been sending their children to school throughout the entire time. And I think it really hinges on, what is your own tolerance for risk? And that's a conversation I think we should have with our families. And I respect a family's decision. One family I saw last week has not done an in-person visit in a year. The kid's A1C runs around 6. He's on the closed loop. They, do an incredibly good job. But I mean, they're the family who, is always wearing a mask, even when they're out walking on a trail alone. So their tolerance for risk is very, very low. And I think we should respect that the same way, we should respect our families who have a higher tolerance for risk. And I think the more important message that we need to talk about now, to keep it simple, I've been telling patients, when it's your turn to get a vaccine, go get in line. And a patient told me the other day, they said, well, I don't trust the government. They're from, rural East Colorado. And I just said, well, will you trust me? Because I really want you to go get in line. And she'll be eligible hopefully in a few weeks because she's 18.
So there've been a couple of questions around the increased incidence of DKA, especially at presentation of type 1 diabetes. Do you think that this is related to, is it pandemic related? Is it related to the virus? What do you think is driving this?
So, previous to the virus, the increased risk of DKA, we're not really sure yet, but what I think it most likely is because we see the Medicaid population, right? That line was really flat. The privately insured population, it was rising. And I think what that is this higher out-of-pocket cost. We did have a survey. We had a paper we published a few years ago with about 60 families and cost. And I couldn't take off time from work. I couldn't get an appointment. Those were concerns that families expressed. But I think the high deductible plans, I think we really need to dig into that. And I think that's a major disincentive to seeking well child care. I mean, so Dan, I have 4 boys, and we've made enough urgent care and emergency room visits with my boys over the years. And I got that emergency phone call from the school a few weeks ago. One of my boys got hurt at school. Of course, it went to my spam filter and my wife had to call. And I picked Adam up. I looked at his ankle. I'm playing pediatrician. And the thought went through my head, do I take him to urgent care? Is this a sprain? Or do I take him to the emergency room because I know I have to pay $250 in my copay, which, I'm good for it. I got $250, put it on my card, that's fine. But there was a disincentive there. I took him to the ER and he got a long leg cast because he broke his tibia and fibula. But there was that, do I really need to take him in? Thought that if you weren't medically trained, I think those families aren't taking their child in, right? We've all taken care of that kid that, somebody literally had to scoop off the floor because they were unconscious. And then of course, that's where we get the bad outcomes. I saw a kid years ago who had a brachial plexus injury with his initial onset because he collapsed and, hurt his arm on the way down. And, to think that you get that ill. So that's pre-pandemic. It's too long of an answer for you. During pandemic, I think it's lockdown related. I think it's just a magnification of the lack of access. We had massive declines in outpatient pediatric care. And so that's what our data show, that I would love reviewers to accept that at some point. We've submitted a few times and just had trouble communicating that message. I really think it was lockdown related. And then when the lockdowns lifted and when people felt safe going out into society, we resumed sort of normal American life. And so our DK rates went down, even though we had huge virus spikes in the fall and people still felt like, oh, we're kind of past this, right? 100,000 cases a day in the US, no big deal, right? People are going about their business. So, we have not seen those DK rates resume, back to where they were in the spring.
So there's a question around the papers looking at risk factors, including age as a risk factor. Have they assessed or controlled for diabetes technology use in any of those studies that you've seen?
Yeah, that's a good question. We did control for technology use in those papers, and I'd have to go pull out. There's really big long tables in the peds and adult papers that I know the adult paper has that one published, that we looked at CGM and pump use. And if I remember correctly, they were significant in the univariate model, but not in the multivariate model, because the Black and Hispanic patients, that was where the really big difference was in technology use at baseline. And so that difference in DK rate and hospitalization was really accounted for much more by race in the multivariate model, and that kind of washed away the tech use. So I think, technology probably does help. I think there's more and more evidence that CGM helps our patients, probably even more than pumps do, but it wasn't really clear from that data.
Folks want to know a little bit about your telemedicine program at the Barbara Davis Center in terms of the support to patients before the visit, the data uploading process, scheduling patients after a visit, working with the multidisciplinary team in the context of the visit. What does that setup look like for you? What's worked and what have you learned?
Yeah, so it's changed a lot this year, and I think that's I think that's what all of us would say. You know, when I've listened to these presentations from other centers on the T1D exchange calls, it's eerie like how similar our experience is. So I hope I can say something that you guys haven't thought of before, but most likely not. We have a very large research team and a lot of research staff who all of a sudden, when the campus closed, had nothing to do, and we redeployed them, and so they really helped us ramp up telemedicine very quickly. And so what we did was, downloading devices is the challenge, right? So we elected to use Zoom and to use Zoom outside of the medical record. Our children's hospital has video connected to the Epic EMR, and we elected not to use that platform, even though that's what I used when I was doing my endocrine clinic over at Children's. But we used Zoom just like we're using now. And that worked well for some families, right? And then some people don't have internet connectivity, and that's been a challenge. So we made the decision early on. Number one was we don't care about A1Cs. I want to connect with my patients, make sure they have supplies, and at least in April and May, I don't want to send you out to a lab right now for routine labs or even an A1C. And we're not going to mess with the hassle of A1C kits because we have nearly 70% of people on CGM. And if I have your CGM, do I even really care about your A1C? And the fact is, like, that's the more practical thing. So we did not spend a ton of effort that I know that some clinics did on A1C kits, and that really hasn't been a problem for us. And then, when some patients can't upload, we did not use that as a reason to cancel the visit. And I know some peds endo clinics said, well, if you can't upload, let's not do the visit. And we decided, no, if you can get online, and if that's what it takes, we don't have data to review. I can at least review sick day with you. I can make sure you have your prescriptions, your refills, and your supplies. Shoot, I could screen share and show you a CGM on YouTube and maybe convince you that now is the time to go get a CGM. So this is time really well spent, even without an A1C or routine labs or even an upload. But we did have our research staff really help us with those uploads this year. And now we've transitioned back to about 25% of our visits are on telemedicine, and the demand for at-home telemedicine has dropped. And we've actually been surprised. So at 25% of our visits are telemedicine, we currently have more open telemedicine slots in the next few weeks than we have open in-person slots. And so we are shifting back. There were some clinics that were not filled yet, and we're shifting those back to in-person. The campus is letting us open up. So that's the other thing I would add, that we have a really good data team, and I have a couple of people on our team who are really good at getting data reports, and we've been sending out weekly reports for, how many patients have we seen, how many of those is telemedicine, and then comparing that to our baseline. So we have a bar graph, that we add a new bar on every single week, and we've been doing that throughout the year. And so that's helped us communicate to our senior leadership, because when they come down and say do more telemedicine, then we can go back and say, well, there's a lot of open telemedicine slots, so no, we're going to open up more in person, and that's what we're going to do. So I think those are the biggest keys for us.
For families who are trying to make decisions around return to school, return to sports or extracurricular activities, perhaps doing camps over the summer, what advice are either you as a clinician or even as a center are you giving to these families?
Yeah, I think that, it's risk tolerance again. And I think with that measured reassurance that I mentioned, I think it's, what would you do for your child who doesn't have diabetes? Do you as a family feel like you need to be more cautious because they have diabetes? I would suggest a similar level of caution, maybe just a little bit more. And then for the children who are not at or near A1C goal, I would say, I really think your risk is going to be less overall, and for the long term, and your risk of DKA, not just with COVID, if we get your A1C down. So how about we think about using a CGM? How about we think about, strategies for helping you be more successful with your CGM? I think those are the biggest points of that we talk about. And, and then again, it's a general pediatric question. Well, what activities are you doing? Dan, my oldest son plays baseball. Baseball is a pretty socially distant sport. And so baseball really lends itself to outdoors in the summertime, pretty safe sport. I have taken that extra canopy and set it up next to the dugout and extra chairs just to spread those 12 kids out and those 4 coaches among a few more square feet, so that if there is possibly spread outside. We know you can still catch the virus outside. I think there was one paper that said the risk was about 17 or 18 times greater indoors than outdoors. I don't know if it, was the best methods. It was more of a natural experiment. So, those are the things that we're talking about. I do have one patient who probably got exposed and got COVID. Her exposure was probably outdoor soccer unmasked back in the fall. She did really well, and unfortunately didn't even have ketones or high sugar. But there is some risk, and some sports and in camp settings are a little more risky. And I know ADA has canceled their camps for this summer.
Well, Todd, thank you for coming back to your roots and joining us at Pestola today. Really enjoyed your presentation as well as your answers to the questions with a lively discussion. And I really like this message of measured reassurance, that this is a time to be prepared, but to continue living your lives, and what all that means and how it can be individualized for families. So thank you. And thank you all for attending Pestola 2021. As a reminder, there will be CME credits offered for attending today's meeting. So be on the lookout in the next couple of weeks for an email from Pestola with instructions on how to obtain those CME credits through Texas Children's Hospital. Also, the virtual poster hall will remain available on the Pestola website for a while, probably the next year. So please check those out. That's also where you can find the Pestola podcast series, which features many faculty from across our member organizations. Finally, I'd like to say a very special thanks to the Pestola Board of Directors, and especially to Dr. Sarah Poon McKay, who was my partner throughout this journey and was instrumental and very flexible in serving as a co-chair and the planning and hosting of Pestola. And last, but certainly not least, a heartfelt thanks to the incredible Dr. Joel Stillman of Cook Children's Hospital, who's been an incredible and steady leader for Pestola. I was able to see firsthand his passion for advancing the mission of this organization. So friends and colleagues, please enjoy the rest of your weekend. I remain hopeful that just maybe we might be together in person again for Pestola 2022. So please stay safe, take care, and enjoy time with your loved ones. Bye.